Good afternoon. Welcome to the May meeting of the Maryland Healthcare Commission. I'm Fran Phillips Vice Chair. As you can see, Dr. Tanio is not able to attend in person, so he's asked me to chair the meeting today. And I am not sure if we have Dr. Tanio or any commissioners on the line. Do we have anyone on the phone? Doesn't sound like it. All right. Thank you. Turning to the agenda, as you have in your packet, the first item, the approval of the minutes. If you have had a chance to take a look at the minutes from the April 21st meeting, and if there are no changes or corrections, I'd appreciate a motion to approve. Motion. Second. Thank you. Second. All in favor? Aye. Any opposed? Minutes are approved. Thank you. So, update, Commissioners, you've received the written update of activities of the centers, and Ben, do you have additional updates to add?
I have a couple things I wanted to bring the Commissioners up to date on, as well as the attendees. First off, as you recall during the legislative session, we went through considerable discussion and debate, and ultimately the legislation pertaining to freestanding medical facilities was passed, Senate Bill 707. That legislation was signed by the governor on May 10th. We are taking steps to reconvene our freestanding medical facilities work group, which is charged with developing a state health plan chapter for freestanding medical facilities. Considerable work had been done last fall. It had then been deferred when it was clear legislation was anticipated. We will be resuming work late in June. There will be, that work group will be re-engaged. We plan to add several other participants reflecting concern that came out of the legislative debate. We're asking them to participate in that. That legislation also included language that required the Maryland Healthcare Commission to establish a work group on rural health care delivery. That planning for that is underway. We've met with the legislative leadership as well as DHMH over the last several weeks. We will be bringing forward in June nominations for members of the work group to the Commission. The Commission will appoint both the chair and membership. And we're getting a significant number of nominees as we go forward. There is an announcement on our website pertaining to the process for nomination. If those attending today would like to make suggestions, they're certainly welcome to. The second item I'd like to bring to your attention is that this past week, the Maryland Health Benefit Exchange voted to move forward with a agreement with CRISP to fund the provider search capability on the Health Benefit Exchange enrollment site. The arrangement that will be used is that the Health Benefit Exchange will establish a MOU with the Maryland Health Care Commission, and we will use our granting authority, which we have to award a grant in the value of $250,000 to CRISP to continue work that they have been doing for several years on the provider search function for the Health Benefit Exchange. The search feature has been something that I think has been valuable for consumers as they consider enrollment in health plans. They can look at where their own providers are participating, which is helpful to them, as well as if they are enrolling in insurance coverage for the first time, can look at the scope and depth of a payer's network using this search feature. Longer term, we expect to be working with CRISP and other state partners to really enhance this provider network capability so that a more robust and broader network search capability can be established going forward. There was some discussion about how we could do this, how the state could do this more cheaply at the Health Benefit Exchange. My suggestion to the other members of the MHPE was that we continue this year, which would be through the enrollment year 2017 with what had been done for the previous 3 years, and then work together to come up with an improved and perhaps more efficient, less expensive framework going forward that it really meets the needs of many state agencies. Lastly, I wanted to bring everyone up to date. I think we've talked about some of the ways we're using the federal government rate review funds to focus providers on improved performance. We had agreed over the spring to consider how we could use education capabilities to reach out to clinicians on educating them on inappropriate use. We decided to focus on inappropriate imaging going forward and to use a framework of continuing medical education to do that job, focusing on inappropriate imaging for patients with back pain. We are engaging one of our private sector partners, the St. Louis Business Group on Health, to work with us on that. And late last month, we brought together the Maryland Development Team, which included several primary care physicians, a number of orthopedists, including our own Commissioner Pollack. The course will focus on providing utilization and cost information to physicians in not only the Maryland, but the St. Louis areas as well. And then we got through this work group process considerable input on the importance of really coming up with two tracks, if you will, one aimed at orthopedists and the second one at primary care physicians, because the sense from the physicians was that really different types of information would be going forward. We'll be working on that process over the summer and hope to have a program in place to test it later in 2016. Lastly, another little item that didn't get into the update, there's nothing concrete yet that's occurred, but the Maryland Healthcare Commission staff, in collaboration with HSCRC and DHMH, are collaboratively working on the generating interest among providers and practitioners in a new CMS solicitation, the Comprehensive Primary Care Plus program. This is follow on to the Comprehensive Primary Care Program, which was launched by the federal government in 2012 in 7 regions, engaging some 600 practices. This next wave of that will engage 5,000 practices nationwide. CMS aims to include 20 regions in that program. The 7 original regions would have preference, but that would leave opportunities open for 13 additional regions. We think the CPC Plus initiative, in that it focuses on enhancing primary care, establishes a reimbursement model which is fairly forward-thinking, in that primary care physicians would be paid a care management fee on a capitated basis. They would also be paid upfront performance awards for meeting performance and quality metrics. CMS, through its model, would claw back those funds if those performance and quality metrics were not met by practices. The program is multi-payer in nature, so the 20 regions will be selected based on the alignment of other payers in the region, meaning that other payers have to agree to participate. The states don't really take the leadership. It's the payers in those regions that would make the choice to participate, and regions would be selected based on the number of covered lives that potentially would be eligible. So our work with the HMH and HSCRC is to try to, at this point, work with payers to identify bottle challenges and pass those issues on to CMS. We can't commit yet to saying there will be an applications from Maryland carriers, both private and the MCOs, but we're continuing to think this is a very important multi-payer initiative that the primary care community has thought would be very important in bringing alignment on delivery system principles forward in a way that they can manage effectively. It moves reimbursement into further along the pathways to value and away from simple volume, and I think it has a lot of possibilities. It is a very ambitious program, and the time frame is very, very tight, so we'll be keeping you updated going forward. The deadline for payers to submit applications is June 8th, so the key point, we'll know fairly soon whether we have enough payer volume to consider further outreach with practices. In meetings we've had over the last several weeks, enthusiasm among the practices has been very high. Enthusiasm among payers has been less so.
Just a couple of questions. When you talked about regions, are the regions already defined, and are they defined as a state, or is it likely it's going to depend on who's willing to play, and then it'll be sort of a catchment area of the payers and providers that are willing to play? Has CMS do they already know regions at this point, or are they leaving it?
So the way that they would define it is that payers would apply and define the regions in which they would be willing to offer the program. So it's somewhat of an interactive process. Naturally, our focus in trying to bring payers together, we've had several meetings, is to encourage payers to apply for at least Maryland as a region. In the 7 regions that are currently participating, with almost all of those are subsets of states, including what feedback we know of the 7, Oklahoma, Arkansas, and Ohio are now in discussions for going statewide with the model. The evaluation results on CPC Classic, I guess I should call it, is that the Oklahoma region did show an ROI. Some of the other regions were close to an ROI, and several were fairly far removed. But I think given the movement towards, through MACRA, the new Physician Payment Reform Initiative, that CMS believes this is a very appropriate way to move forward. I think it's just very tight time frames to do all this.
Thank you, Ben. Any other questions for Ben on the update? A lot of activity for sure with the commission and the staff between our meetings. I do want to take a minute and just recognize Ben's leadership and the staff's hard work in developing a forum here at the commission for primary care interests. We now have a primary care council. It's a very robust council. It just met again yesterday. I guess we're on about once every 4 to 6 week schedule of primary care leaders, physician practices around the state. This as well as several other initiatives, along with leadership from HSCRC, were discussed yesterday. This is a good forum. This is a good recognizing the critical importance of primary care in health care delivery and financing. There's certainly been tremendous attention to hospitals in our state, but looking at how to support the primary care sector is really something that Ben has taken on with staff here and has done a remarkable job. So I just want to thank you for that. Okay, Ben, no other center director updates? We're good. Okay, all right, good. Well, let's move on then to some business. As you can see, the third agenda item, we will be taking up a certificate of need application. So at this point, I'd like to invite Kevin McDonald to come forward. Kevin, as you know, is the chief of certificate of need. He will present staff's recommendation regarding the CON application filed by Suburban Hospital to construct a 300,000 square foot building addition as part of a larger campus modernization effort.
Thank you, Commissioner Phillips, and good afternoon to all commissioners. This project is essentially a partial on-site replacement to modernize an aging physical plant that is considerably undersized for modern healthcare delivery in virtually all functional areas. It would entail a 300,000 square foot building addition and an 18,000 square foot renovation. The primary focus of the project is to create private patient rooms and to modernize the surgical facility, although there are many other aspects of the project as well. Those are the two key areas. There would be 54 additional private rooms built in the new structure and shelled space for 54 additional patient rooms. Those additional shelled space, which most likely use is for beds in the future, is not for expansion of bed capacity, but to continue to allow the hospital to migrate from really an older facility to a more modern facility. The primary reason that this is shelled rather than going to beds initially was budgetary. Essentially, the facility had a certain budget limit for this project and thought it more prudent to shell the space now and then come back later with that project. The other key addition is replacement of the ORs. There would be 14 ORs, which is a reduction of 1. They'll be significantly larger than the present sized rooms, which are well under the standards of today. Would also significantly improve the OR adjacencies to the emergency department and to central sterile. The project will also include shelled space intended to be physician office space. Unlike most hospitals, Suburban does not currently have a medical office building on their campus or adjacent to their campus, which creates a good bit of inefficiency for physicians back and forth. So shelled space would be built in the new facility with the intent to be finished off in the short term for medical office space. The project will also significantly improve the campus circulation inside and outside. The cost of the project is $200.5 million. Funding would be $91 million in cash, $38 million in philanthropy, I think most of which, if not all of which, is already raised, and just a little bit over $71 million in bond sale proceeds, as well as interest on those proceeds. The hospital is not seeking an increase in its GBR to cover the project costs for either depreciation or interest. In looking at the need criterion, the need, again, is primarily to modernize the facility, to create private rooms, renovate the surgical suite or update the surgical suite, improve campus circulation, and create physician space. So those are the project drivers. In terms of bed need for the project, the hospital is currently authorized to operate 236 total acute beds, of which 209 are MSGA. After the project, the hospital's operational capacity would be 229, of which 202 would be MSGA. The physical capacity of the facility will increase because the current inventory of semi-private rooms will remain in place, although they're going to be used as private rooms rather than semis. But nonetheless, on the books as physical capacity, there would be an increase. Currently, Suburban has 50% private rooms in its med-surg component. After the project, it would be 100%. With regard to the need projections for beds, over the 7 years between 2015 and 2022, Suburban projected a 7% growth in MSGA discharges. Our projections, MACC projections, indicate that a more modest census is likely. However, only 54 of the beds are being replaced through new construction, with another 54 likely to be replaced in the future. That would still leave close to 100 beds in the older facility, even if and when that shelled space is finished. We would anticipate that the use of the older beds, should the MHCC projections be closer to reality than Suburban's projections, that the hospital would probably choose to not staff those older rooms, and thus we're not really concerned that there's a difference in our bed need projections. I would point out that if this was, like some of our other recent projects, a total replacement on a new site, we'd probably be looking at this a lot differently in assessing the bed need. In terms of viability and financial feasibility, the resources are clearly available to the applicant, and there's a relatively low percentage of the project financing being borrowed. Both our staff and HSCRC staff judged the assumptions the applicant made to be reasonable, and based on those assumptions, their financial projections were credible and project to continue to operate with positive margins. HSCRC's memo did include a caveat, however, regarding possible utilization declines. And so, the question arises, if that does happen indeed, what would be the impact there? And really, we have a complex system in Maryland. The impact on the bottom line would really depend on where that, what caused that volume decline. If it was not a decline in market share, a market shift, then essentially the hospital's bottom line, the GBR would remain the same while their costs went down. So that would actually have a positive impact on the hospital's financial standing. Now, in such a case, prices would rise, but the overall cost to the system would be lower because quantity is going down. And that's really what the desired outcome of the Maryland Medicare waiver. Given that there's a substantial proportion of the beds staying in the old building for some time, a setting that has minimal capital cost requirements, Suburban would be able to cut its costs as well in the event of volume decline. So there's really not a critical downside in terms of those beds and a utilization decline. There's, in staff's assessment, no impact on other providers. This project is not dependent on any new services, or a key component is not any new services, and the applicant is not projecting any market share shifts in its assumptions. So it really would be a continuation of their current role. In summary, staff analysis at the relevant SHP standards have been met, as have the criteria in COMAR 1024-01. There are some specific conditions in the recommendation relating to restricting the use of the MSGA nursing units to one patient per room unless getting MACC's approval. Some conditions on the use of and reimbursement for the shell space, as well as exclusion of $2.36 million calculated as excess construction costs from any future funding request that might be made to HSCRC with regard to the project. We do have representatives with us this afternoon from Suburban Hospital. Jackie Schultz, the interim president, Joe Lindstrom, the VP of Operations, Margaret Fitzwilliam, the Director of Capital Renovation Planning, and from Johns Hopkins Medicine, Ann Langley, Senior Director, Health Planning and Community Engagement, and Spencer Wildonger, Senior Project Analyst. Also with us today, related to the project, is Andy Solberg, who was a consultant on the CON.
Thank you, Kevin, for that report and for the work that you've done with staff and the recommendations that you've put forth for us. And so with that, I'd like to open it up to some discussion. And I think procedurally it would be useful to have a motion on the floor to approve this CON request, and then we'll open it up for discussion. So would there be, thank you, Commissioner Moffitt. And is there a second? Thank you, Commissioner Pollak. So with that, let me open it up for questions, discussion with Kevin or with any of the representatives from Suburban that are here.
There was a mention of shelf space for future outpatient physician office practice. Is that intention for that space to be regulated or unregulated?
Our understanding is unregulated. And that is one of the conditions, that if it is used for regulated space, then the it is the fifth condition in your report. In calculating any future rates for Suburban Hospital, the HSC shall exclude the capital costs associated with the shelf space until such time as the space is finished and put to use in a rate-regulated activity.
It's on the campus. It has to be regulated if they're going to use it, right?
No, you can not necessarily. So right now there's no plan for that space to be used for regulated outpatient activity. It would be potentially used in the future for unregulated, and if they wanted to use it for regulated, they'd have to come back. Is that correct?
I'm Margaret Fitzwilliam from Suburban Hospital. Yeah, we do not have any plans to put any outpatient regulated activities in that space. It's truly to serve for medical offices like most hospitals have on their campus, for specialists to support the emergency department and surgeons so that they're not driving back and forth to their offices.
Great. Thanks.
Thank you. Other questions?
Yeah. You gave a certain number of kind of conditions that might happen if utilization were to drop. And I guess I was just wondering, was that, is that actually your projection, that utilization in that part of Montgomery County will drop over time, or is that just sort of trying to be cautious, what if, rather than you'd expect?
You'll see that there are a number of different scenarios in the report in terms of different projection methodologies, and they all point to either lower utilization or basically lower than Suburban projected, and that would be true across the whole county.
Okay. But that wasn't based on some notion of that hospitalizations are in general, a trend is going down, so we should...
Yes, it is.
It is.
That's based on a lower utilization trend and projecting that trend to continue into the future.
And then offset by the growth in that part of the county just in general population? Or
partially offset, because there still is a projected total decline.
Okay. Yeah, it's a fairly established, I mean, it's not a lot of new housing.
The effect of the two together
right.
is relatively flat, but I think most of the projections that we've done show that there's going to be a decline, modest decline.
Thank you.
No, I just want to add, following Commissioner O'Grady's point, there is a general decline in hospitalization utilization throughout Maryland, and in fact, it's a nationwide trend. There's nothing unusual about this. So, in other words, we're looking at a very, very gradual, and there are a lot of reasons for that. I'm not sure exactly what all the reasons are, but in fact, all of the national data shows that is the case.
Other comments, questions? Started?
So, this is my last meeting where I can be the new guy, so I have to ask all of my stupid questions now. So, 3 new commissioners next time. And I just want to make sure the motion that's on the table, there was a final order appended to the staff report. I take it that's what the motion is, to approve the final order with the 5 conditions listed on it. Okay. That was, like I said, it's a stupid question. Just want to make sure I knew what I was voting on.
Anything else? I have a question in connection with the local support. First of all, this is not a contested CON. There's no interested parties, and I did notice that the Montgomery County Department of Health and Human Services sent a letter of support for this modernization. It is my recollection that the community surrounding Suburban, the neighbors, have had strongly held views with regard to the hospital's construction and expansion proposals over the past. And so have those all been resolved and reconciled, and maybe you could speak to that community concern?
They are from a legal perspective. You know, every day we are good neighbors and respond to their questions, but we actually filed the zoning application in March of 2008 and got through the final legal hurdle in January of 2014. And it's not the way the process, you know, none of us would like to plan a hospital that way because we were forced to design the footprint and work that way. But all of the legal matters are resolved with the community. And so we have all of our zoning approvals in place.
Any other questions? We'll call the question. Commissioners, all those in favor of adopting the certificate of need, that's docket number 15/15-2368, the modernization for Suburban Hospital. All those in favor, please say aye.
Aye.
Anyone opposed? Motion carries. Thank you, and your CON is approved. Thank you. Congratulations. Next item is seems to be a standing order of business that we have in connection with approval of the release of the database. I'd like to invite Srinivas Sridhar to come forward at this point. As you all know, Srinivas is currently the Chief of Cost and Quality Analysis and will present the staff recommendation regarding the Lewin Group's request for access to the CB Maryland Claims Database under the Commission's data release policy. Before you do that, Srinivas, I want to take the opportunity to thank you on behalf of all of the commissioners for your service here. First, as the Center for Quality Reporting and Measurement Director, and most recently, Chief for Quality and Cost Analysis in the Center for Analysis and Information Systems. You all know Srinivas. When there's tough questions having to do with data and how to interpret data, Srinivas is on the scene. And it is clear that your commitment to accelerating our work, the Commission's work with regard to this database, with workforce studies, and your commitment to work with state partners has been second to none. So it is going to be a tremendous loss for the Commission. We want you to change your mind. We know you won't. So in that regard, we wish you the very best in the future. Congratulations.
Thank you so much, and it's been a great pleasure and honor to work here, and I've grown a great deal and learned a great deal from the folks here, and this has been a wonderful place to work and have wonderful colleagues as well. So I wish the Commission nothing but the best and hope our paths will cross in the future as well.
Absolutely. That would be a dream.
Thanks. So with that, thank you so much. So today we are going to review a application from the Lewin Group for data from the Maryland Medical Care Database. So what I'm going to walk you through is just a quick overview and a reminder, especially since we have a few new folks since the last approval, of what are the criteria that we generally use, and then give you a quick overview and answer any questions. So the first set of things that we use for the framework of for evaluation is to understand, is it an appropriate use of the data? Is the data appropriate? Is it permitted? The second is this a qualified user? Do they have expertise and experience using this kind of data? Would they be able to do this work well and use it appropriately? And finally, is data security and data management plan, is it, are they able to keep the data safe and give it access only to qualified users, approved users? There is also an IRB process, but these are our criteria preceding the IRB approval. So the Lewin application, in that framework, it is indeed an appropriate use. Lewin is requesting this data as a contractor to CMMI to support CMMI in its monitoring and operations for the Maryland hospital payment model and the all-payer model that HSCRC administers. The scope is broad for CMMI's contract with Lewin, providing support for everything from analytics to assessment, monitoring, evaluation, quality. It's, I think, dependent on CMMI's needs, they will do a variety of analyses over time. So we certainly think that's an appropriate use of the data. And as you all know, Lewin has great experience in this area, has similar projects in other states, has extensive expertise with this kind of data and policy analysis. Finally, their data management plan is good and acceptable. They plan to work in the CMS's VRDC, their data enclave, the secure data enclave, and will ultimately provide access to another applicant that has been approved here before, RTI, who is the evaluator for CMMI for the hospital model. So we believe they are able to keep the data secure, certainly. They are asking for data going back 2010 and going forward. We probably won't get all the way to 2018. I think they'll actually probably end in 2017. There will be, the release is, you would approve this release. Of course, what they will get access to is data available now and then add a year each time that it becomes available. That would be the overall approach. This is for commercial data only. They have independent access, obviously, to Medicare and to Medicaid data as well. The MCDB, just as a reminder, this includes the eligibility, that's membership information and claims data that is professional services, that's and institutional, all institutions, hospital and non-hospital facility billing, pharmacy services. There are no direct identifiers provided in this data. There are some indirect identifiers in there. The IDs will be masked to permit linking across files if they get other files like this, and not identifying payers. Their application has been reviewed by Chesapeake IRB, which is the MHCC designated private IRB. It has been approved under a few categories, including a waiver of informed consent, and also a related item under protections for children. So they've provided approval under their authority to waive it as exempt from review. So the next steps are, if approved by the Commission and commissioners here, the MHCC will execute a DUA with Lewin and release the data to them, and then do ongoing monitoring and compliance under the DUA. So with that, I'm happy to answer questions. And
okay, thanks, Srinivas. First, can I get a motion to approve the release to the Lewin Group? Thank you, John. Is there a second? Thank you. Questions for Srinivas?
So, I mean, on its basis, everything looks totally fine, looks great. I have a few questions about kind of the reciprocity here. So in their plan, they're going to do some, looks like fairly sophisticated linking with other databases. And I guess to a certain degree, just thinking in terms of this, will MHCC get copies and documentation for those databases, or are we just giving and not getting?
So as a general statement, I think we're a provider of data. I imagine, and I should mention, sorry, I didn't at the beginning, Isaac Burrows is here from CMMI, and so we can ask him to come up if you have further questions. But I think, in general, I think there's a partnership with Maryland and HSCRC and CMMI in these efforts, and there is a fair amount of back and forth happening in terms of how data is done, what is the thinking around these, and so forth. There is no explicit requirement in this arrangement to provide any data back or any linkage back, and I think I would imagine for some of those particular databases, we need a DUA to have access to those as well. So I think perhaps it could be arranged if there's specific interest, but that's not the agreement being made.
Okay, well, I guess I understand that. It was certainly not a compelling kind of a thing. But in terms of professional courtesy, if we're providing you data, you're enhancing that data, in effect, by doing these linkages. And then just sort of, could we get a copy when you're done? And I think that there's overall, in terms of just, it sounds like it should be a fairly nice, powerful set of analytics they can generate when they're done, which, candidly, I wouldn't mind the state of Maryland having the same kind of capabilities as that, because they're clearly going to do a lot of work here. One other question really, and it's also candidly, and nothing against CMS, but at times when if there's going to be analyses of, especially what has gone on in Maryland, that will come out of this and maybe the RTI evaluation, it certainly would not be bad for the state of Maryland to have the same data so they could run parallel analyses rather than constantly working off someone else's data. It's just not a position of strength, candidly. So that idea, I'm just thinking the capabilities and the ability to allow, us to do very powerful things that they're already going to spend the money to create. The other question I had is in their line where they talk about that, or when they talk about their linkage, they also say, we will not do any of the Maryland claims database. We will not link it with any other claims or enrollment data. That sounds like, is that something we asked for, that they not? I mean, because as you can tell by who they're going to staff this out, a bunch of this is being done by Optum, which is really United Healthcare, which certainly sits on the largest private claims database in the country of whatever, 50, 60 million lives. So I think there's sensitivity there about actually saying.
Sure. I think the idea and the prohibition that we have made also is to make individual level linkages. I don't think this is a prohibition against using it in conjunction with other claims databases that they might have access to. Certainly, part of this evaluation, we're only giving them commercial data. They're going to be using Medicare and Medicaid data as well. So I think they're free to do those analyses in conjunction with other sources of information. The central thing that we focus on is trying to, in any way, re-identify anyone and link them to other sources of data that might have other claims or other information. That's the focus of that review for us.
And I would assume we're already, because the feds are already very careful about that with the Medicare and et cetera, et cetera.
I believe so.
So I think we should be good on that. I guess what I'm wondering about is for future work by the commission and by other parts of the state of Maryland government, there's this notion of, there's a number of these questions we hit, which if we could sort of also know, well, is this the same pattern you see in the Pennsylvania and Delaware data? Is this what you would see regionally? Is this what you would see? We've got Baltimore. How does that look like compared to Pittsburgh? Or however you want to think about that. I'm just talking analytic capability for the state of Maryland. Again, they're doing it. I mean, this is a nice analysis plan. This will be great if they can pull this off and have the kind of quality matching that they're attempting to get, which will be hard because we're not giving them unique identifiers. So we're making their life more difficult.
We're giving them a unique identifier for a member in the data such that they would be able to follow the individual.
Okay, so it's a scrambled.
It's a scrambled ID.
Got
That's right. But so they wouldn't be able to identify that it's me or you, but they just know it's an individual, follow their use across settings.
I guess my recommendation would be, if we're providing this data, and there's no strings attached here, but to simply ask for a professional courtesy to get copies of these linked files back for state of Maryland use is simply a professional quid pro quo. That I don't, they're making copies for themselves, one more for us, I think would just put us in a stronger analytic position than we are under the current arrangement.
Good afternoon. I'm Isaac Burrows from CMMI. Appreciate the Commission's consideration for this. We certainly have a number of already executed DUAs with other states around their all-payer claims databases. State of Vermont comes to mind right away. We also already have an executed DUA with HSCRC. We provide them monthly, quarterly, and annual files. They also have access to our virtual data environment where they can go in at any point and have a gander. But what you're talking about specifically, obviously, is you would want copies of our analysis.
No. Because I think you have your own. I mean, that's your own professional prerogative on that. I'm talking about what you're doing here, where you're linking. I mean, the idea of a traditional data use agreement, the DUA, is the idea of raw data being brought in. your guys have a plan here to do really taking it to the next level with being able to link, and this is something that has plagued these kind of analyses forever. You see the claims, but you don't know, is this person highly educated? You don't know what they're in. You don't know any of that other kind of demographics and other variables that you really need to know to answer your policy questions. And you guys have taken what looks like a big step in trying to be able to solve that. And CMS, to its credit, along with Census, is really where the most kind of groundbreaking work is being done in this ability to link across different data sets. So I guess all I'm saying is no, it would be back. It would not be, you'll do your analyses however you want to do them. But I think it would be great if the state of Maryland could simply, after you've done all this heavy lifting to link these files, if we could simply get a copy of them as well, especially the ones that include Maryland claims, so that we could simply do our own set of analyses, et cetera, et cetera. It would not be somehow stepping on your toes in terms of your analyses. It would simply be, if you've done this to create these databases, boy, we'd love to have a copy.
Sure, and I'm happy we can have further discussions as we kind of move along this process. Happy to incorporate our counsel and privacy office as well.
No, I think Commissioner O'Grady has really asked a very important question here. For the Maryland Healthcare Commission, we are a regulatory commission. We have a lot of responsibilities. We've got a range of things we have to do. I am very familiar with the Lewin Group. I have had professional experience with them in the past. They are the gold standard in the private sector as far as my personal experience is concerned in doing this kind of work. So the fact that you're working with them is really, it's terrific. I think I strongly support what Commissioner O'Grady has outlined here, because frankly, for the commission, it would give us a level of power in our own intellectual analysis of these things that is something that would be very beneficial to the people in the state of Maryland.
Other thoughts, other comments on that? Commissioner Sargent?
Thanks. So every time I ask one of these questions, it reminds me of why I went to law school. But I'll try. When we're talking about linking data to another data set, this is something that's going on within Lewin. Our data is staying within Lewin, even though it's being linked for Lewin's use, but it's not sharing that data with the folks who have the other data sets, right? So they can link all they like, they're keeping it within their borders. It seems to me there may be a concern if we're asking for that back, that whoever they're linking to may have an interest in us, whether or not we have that data, because I think we would have a real interest if somebody else were giving data to CMS and it were being linked for CMS's research, and that person, that entity wanted a copy back. We would be real interested in whether or not our data was going out the door somewhere else. And my understanding is that's not the case here. Is that right?
Right. I mean, the ones they list anyway are all the kind of the big public files that you would, the area resource file. That we're mostly talking either HHS or Department of Commerce census sort of files, I think, from what I read here. So we're talking about that. I mean, that's what triggered my second question, was the idea of, but it's you can see from the staff they've listed on, it's going back to the Twin Cities. It's going back to the mothership there at United Healthcare to be run by Optum that sits on, really, other than Medicare, has the largest, most comprehensive claims data in the world. Now, I can see that if I'm sitting on the board of United Healthcare, maybe I'm going, I don't know that I want to share that with the state of Maryland, and that's a reasonable thing to say. But I couldn't quite tell whether that kind of a linkage to something like, whether Optum's kind of, they're all owned by United Healthcare, so it's not really a subcontractor, but whether they would also be linking to those kind of claims files or not.
I'd like to clarify one thing in terms of the data management plan. The agreement, and please correct me if I'm wrong here, is that all analyses in this data is to be housed in CMS's enclave. Correct? That's correct. So it's not, the data is not to flow elsewhere, and I think that was your point. And yes, that is the case. And I think the matching and identification, so to speak, being done is not at, let me identify John Smith and find his demographic information. We're talking about probability matching. Right. We're talking about saying we understand something about a given zip code and try to identify and link up, be it something like an area resource file, be it social demographic information. And I think that is why what's being asked is, that type of analysis to enrich data is indeed valuable and would be valuable to any number of potential users, certainly in Maryland. I think that's the reason the question's been asking, not can I link it up to other people's claims data, which I can totally understand why then you or United or anyone else who submits data to us would have major concerns about that. I don't think that's what they're trying to do.
Well, and to be clear, our contract is with the Lewin Group, and there are strict firewalls in between the Lewin Group and Optum and ultimately United. So those aren't even coming anywhere close.
Okay. And I assume there'd be, in terms of our staff, there's no problem with using the kind of data enclave methodology that is being discussed here.
No.
I mean, it is the most secure. It's state of the art.
And indeed, that's how we store our data. We used to house it internally, but now as part of our MCDB contracts, we also have a secure data enclave with comparable securities.
Yeah. Yeah. So, I mean, CMS is building an amazingly powerful tool here. If they're able, I mean, it's heavy lifting. I mean, good luck with this one. But it would be a powerful tool that it would be great to have a copy of it we will be applauding from the sidelines as you do your heavy lifting.
Well, and again, this is in conjunction with some of the work that this commission, HSCRC, DHMH has been doing in work towards future iterations of the model, whether that be the inclusion of CPC Plus, as was alluded to, other ACO models, et cetera. So as we are already working with Secretary Mitchell, others at DHMH on this future iterations of the model, this data is useful for that as well.
Yeah, I just wanted a little clarification around our role here in this, because I agree with Commissioner Grady completely. The data set would be very, very powerful for us to have and be able to use in future endeavors. But I think the question that's before us now, and correct me if I'm wrong, is whether or not their utilization of the data is appropriate, and not for us to negotiate the terms of a release of our share in exchange for something back.
Well, it's mission creep, so yeah.
I think I used the term professional courtesy.
Yeah, okay.
Thank you for clarifying the motion.
Yeah.
Great discussion.
I just have one last question. When it says that you're not planning to link data from our database to other claims for enrollment data, does that include Medicare and Medicaid data? I take it you wouldn't actually be able to do that because you'll get a decrypted ID for a member from us that may or may not match what you have for Medicare anyway.
Exactly.
No, I think the idea is that if you were to say, one of the interests in the hospital model is to do geographic analyses, so say this notion of total cost of care in a geography, you would want to use private Medicaid and Medicare data. It isn't necessarily that you're trying to identify, again, John Smith, who ended up entering Medicare during this process or something like that, and follow that person. I don't think that's the goal at all. Rather, it is to use them in conjunction and then perhaps enrich it with other information from that geography, like the area resource file or census data, as mentioned, other resources to enrich the analyses. I think that's the goal.
Yeah. Yeah, that's right. I mean, you can imagine, so in this all-payer model, we obviously are monitoring things such as cost shifting between payers, et cetera. So,
yeah. If you want, I mean, HIPAA is quite clear. I mean, you can go to someone that's referred to as like a neutral, trusted third party, and you would show your algorithm for scrambling their Social Security number, the CMS algorithm for scrambling the Medicare number. But again, that's, talk about IRB. It's a very careful to actually, if you had something that justified I really need to know about the retiree community that has Medicare, and then an add-on for, employment-based retiree or whatever. But again, it's a lot more hoops and privacy.
Just to be clear, the data that they're receiving from us has a scrambled member ID and has only month and year of birth, does not have date. It has gender and zip code. That's sort of the extent of the identifiers, aside from the PHI elements that are of course there in the data. But it doesn't have the data necessary to do the kind of matching that you're suggesting, so it wouldn't be possible.
Okay, let's turn to the motion then. And just to restate the motion that was introduced was to approve the release. Of the MCDB database to the Lewin Group under the application that was submitted. And Sorry?
I'm making the motion.
We already had the motion on the floor.
We did?
Did we have the motion? I think we did. You want to really make that motion? Well, maybe that's a motion for some professional courtesy. I don't know, but I appreciate that. So all in favor of going forward with this application by the Lewin Group? Aye. Is anyone opposed? All right, thank you. Thank you again, Srinivas.
Just one, Isaac, can just stay there 1 second. This is sort of an after action comment. I think that given the significant interest in this exercise and what would be the outcome of this, we'll continue to talk with you a bit about how some of the commissioner's vision might be actuated without affecting. We understand this DUA really needs to go forward. Lewin is very anxious to get this information, but I think minimally, I think it would be very valuable if your contractors made a periodic presentation to this commission in terms of what progress they're making using this information. It is also notable that Mr. Burrows noted that there's a significant investment by CMMI in making sure that very detailed claim feeds are made on a timely basis as possible to HSCRC in terms of what they're providing, which is very rare, if not unique to states. They are similar information is being provided to some ACOs, but I'm not aware of very many states that are getting detailed, sort of very immediate and raw claim data being sent to other states. We're getting that on behalf of our need to monitor performance under the waiver, and we'll at some later date brief you on that. Perhaps ask our HSCRC colleagues to join in that discussion as well. So, sure.
Thank you again. Very good discussion. So let's turn to the next item. And I'd like to invite Ken Yates-Trotman to come forward. Ken? This is the item on privately insured spending report for 2014. Ken Yatesman, just by way of background for the commissioners, methodologist for the Cost and Quality Analysis Division, will present the highlights of spending and utilization patterns for Maryland residents insured through the individual, small employer, and large employer markets. Mr. Yates-Trotman has been appointed Acting Chief of Quality and Cost Analysis, congratulations, and will assume many of Srinivas's duties. Ken is an actuary by training and has been working with our partners at the MIA to support expanded rate review using the database.
Good afternoon, Commissioners. Before we get into the presentation, I just want to bring to your attention a few takeaways from the detailed draft report that you got last week. We see that the total per member per month spending across all markets and service categories increased by about 3% from 2013 to 2014. The total members as of 12/31 for the individual market increased by about 26% over a year ago. Total PMPM spending in the individual market for all services combined increased by over 30%. Utilization per 1,000 members increased in the individual market for all services categories, ranging from about 16% for professional services to about 51% for prescription drugs. Unit costs for all service categories increased in 2014, except for inpatient facility services, where unit costs showed a decline across all markets. And finally, PMPM spending for inpatient facility services decreased in both the small group and large employer markets, but increased in the individual market. For those of you who are not familiar with the report, I'll give you some background. The Maryland Care Commission is required to report annually on healthcare spending and utilization. The data that is used in this report is from the Medical Care Database and uses 2013 and 2014 data. The data filter for this report is for fully insured private plans for Maryland residents only. And the report study variations by market segment, geography, age, and service categories. For this year's report, we have a special focus on the individual market, and there are a couple of reasons for that. Many individuals with significant medical conditions who had previously been covered through state-based high-risk pool have transitioned into the individual market since the ACA took effect on 1/1/2014. Also, many individuals who did not have health insurance prior to 2014 have also entered the market as well since the ACA enactment. This first slide, we look at the individual market enrollment, and this shows members as of 12/31 and member months for 2013 and 2014. We see that the enrollment increased here by about 25% for both the end of the year and member months as well. Here we look at PMPM changes by service category for in the individual market. We see that the overall PMPM change went up significantly by 31% from $208 to $273. And when you look across service categories, we see that the major contributors were the prescription drug at 62%, followed by the outpatient facility at 46%, and not too far behind, professional services and the lab and imaging at just under 30%. Well, one would ask, well, what are the reasons or drivers for these PMPM increases? Is it utilization driven or is it a cost per unit driven? This exhibit shows PMPM utilization per 1,000 members and the cost per unit changes by service category for the individual market, 2014 over 2013. As we could see from the green bar, that the increases are purely driven by utilization, of which prescription drugs have shown the largest increase in utilization at 51%. Another note here is that the cost per unit increase across all service categories except for inpatient facility, which show a decrease of about 16%. Here we look at PMPM spending by service category across markets. We can see from the individual market, despite the PMPM increases in the individual market, this market continued to have the lowest PMPM at $273 compared to the other two markets. Small employer has the largest PMPM in 2014. However, as you will see in a few slides ahead, this was the only market that showed a decrease in PMPM of about 2% across markets. And a little note here, we could see that professional services have actually showed the lion's share of PMPM spending across markets. This exhibit shows is similar to the previous one you see, but this shows a distribution of PMPM spending by service categories and market. And we can see here again that the professional services, the green bar in the middle, have the largest contributors to the PMPM spending across markets. Now we look at PMPM spending changes by market and service categories, 2014 over 2013. And as no surprise, the usual suspect is the individual market, which showed large increases. But a takeaway from this exhibit is that, as I previously noted, that the small employer market had experienced a decrease of about 2%, and this appears to be driven by the decrease in inpatient spending of about 16%, followed by approximately 4% decrease on prescription drugs. Lastly, we look at the out-of-pocket and reimbursed shares of total spending by market. As we could see from the slide, that the individual market has the largest out-of-pocket spending at 29% across all markets. And this concludes my presentation. Any questions?
Thank you, Ken. It looks like we have a, this is listed as an action item on the agenda. So the idea is that you're seeking commission approval to release this report in a public on the website. Is that?
That is correct.
How's that? Is that correct? Is that how that's envisioned?
That is correct, yes.
Is that how it's been done in the past?
That has done in the past. That's correct, yes.
Well, with that, could I get a motion to release the report as Ken has summarized it? Is there a second? Thank you. Second? Questions? Sorry.
I guess just a point of the report that's being released, is that the one in our packets? Because the slide presentation was a little different.
Right.
Well, the detailed report I sent, we were sent last week, shows a more detailed view of the report. This shows highlights of the report.
But what's being released is the more detailed one?
Yes, yes, yes. This is just for this presentation.
Was that marked draft?
Yes, the draft copy. The draft copy.
That's just a formality.
That's the formality, yes.
Not,
yes.
not any change in content.
Right.
And then I had a more substantive question. I noticed the prescription drugs was by far the highest increase
right
over year. Have you looked at the different categories, and are we able to look at the different categories, like generic versus branded versus specialty, to see where that growth is?
Right. We have not. This is a study we began to look at, but in the essence of time, we were unable to complete. So in our next update, we will actually provide that information.
It's sort of my understanding that in specialty in particular is where that growth is occurring, and it's really a new development that I think we should look into, keep an eye on. It would be useful to know, where within a broad category, which services are causing the increase, which utilizations change.
Yes.
That's work in progress?
This is a work in progress that we will actually look into to actually have a study to dig into the different drugs and to find out which ones actually are driving the increase in utilization.
That's work that we're doing in-house, or are we?
This is work that we are doing in-house and also with SSS, our contractor.
And the time frame for that is roughly?
Time frame for that would be.
Go ahead.
The time frame for that we within maybe a couple of months. Is that correct?
I would say we had a fixed budget for the study that was the analysis that was conducted by SSS. They did also look at the prevalence of diagnoses to see what happened. So we know there was an increase in diabetics, there was an increase in hypertension and
depression as well.
And depression as well. So we had an idea of that, and then we are going to be conducting the drug increases ourselves, but they're driven, of course, by the diagnoses. So that's the foundation.
So don't take my question as critical of the current work at all.
No.
I would love to carve this up.
Curiosity,
100
yeah.
different ways. And I have one more question. Have we considered looking at, if you look at the risk adjustment program that the feds are running for insurance, they're assigning illness scores to individuals to figure out where they are. we looked at doing something like that to figure out where the spend is going relative to how sick or well the various folks are?
Well, in
Individuals who are not known.
in the report, where we focus on the individual market, we show that the risk score increased from 0.19 to 0.24 from 2013 to 2014. So that has shown that the population have surely deteriorated, and that was as a result, as I said before, of individuals entering the market from the high-risk pools and also the uninsured as well.
Right. And one way to look at that we might think about for the next time is we want to know how much of the healthcare expenses are going to the sickest 10%, sickest 15%, sickest 20%. I think might be instructive.
Yes, that is a worthy analysis that we would actually do.
Just very briefly, fast forward, it's released to the public. You get a call from the New York Times. What's the headline? What's the headline? Put it in context for us. What's the story being told here?
The story being told here is that the individual market have poor experience, and that we see that actually utilization increase in prescription drug and outpatient facility. We see a lesser increase in inpatient spending of about 9%, but this individual market seems to be the driver of the spending in healthcare.
Now, if sick people are getting cared for, that's a good thing.
Right.
But, so that's probably what I'm trying to get at. If we're getting people to care and they're actually getting cared for, they're getting their prescriptions, they're filling them, they're taking them, yeah, it can cost more, but that's how we get people healthy. But is that the story?
Right.
Or we have a problem here?
No. I would say, yes, you're right. The ACA is doing its job. That's the ACA is doing its job. Right.
Well, but can we kind of dig down into the patterns here? What you also said was that the high-risk pool was dissolved. Right. So this is what happens when you take apart a high-risk pool. It means the individual market has to, it absorbs those people. It seems to have done it effectively.
Right.
It means your risk score profile, if you want to think of it that way, the population goes up,
right,
and the spending per member per month goes up. So it's not clear to me, and correct me if I'm missing it in the data, that there's any more spend necessarily going on here. We've taken two populations and we've merged them together, and we're seeing an effect that would have been expected and is probably, if you kind of reverse engineer, is the whole reason why they set up a high-risk pool in the first place, so that you could have people come into an individual market without that subsidization going on for the very, very sick. So we're seeing that. What I don't understand, to your point, is what part of this is the ACA? Are any of these people in the exchange, or are they still in what I think of as traditional?
No, this is a combined, both non-grandfathered and grandfathered products.
Okay. So, but it is the traditional independent, whatever, individual market.
Yes, individual market.
Okay.
Yes.
So we're not seeing that ACA, other than maybe we have some people coming in because mandates and whatnot. They have to have coverage.
So just to clarify, so this is the combined individual market, both the exchange.
Oh, it did.
Yes.
Oh, okay. Okay.
Both
Good.
the exchange.
Good. So it's not the traditional. It's the combined with the exchange
Yes.
people in there. So we've got at least a little better pool to spread this over. So, but it is you do away with your high risk pool.
Right.
Your risk score on average is going to go up, and your spend is going to go up. Do we have a notion whether there are the mix of new people? I mean, how big is this pool compared to what it would have been individual market plus high risk pool in the past? Have we seen an increased enrollment?
Well, another way to ask that question is, of the growth in the individual market, what proportion of that growth came from the risk pool, and what proportion came from newly enrolled people, presumably through the exchange? Presumably not formally insured.
I don't have that information that I could actually.
Well, I don't mean like nail it to a.
Okay.
Mm-hmm. But was it half and half? Is it the enrollment at MHIP was a known?
So yeah, we know. So the MHIP population at its zenith, or more probably better to say, in 2013 was about 20,000 covered lives. So in 2014, most of those folks migrated into the exchange segment of the individual market. They were subsidy protected, so they went to the individual exchange as opposed to remaining in MHIP. Although they were not, the high-risk pool was not closed until January 2015. Then everyone was migrated over. It's my recollection that even late into 2014, we were looking at about a third of the MHIP high-risk pool still opting in to stay in the MHIP pool. So what you're seeing in 2014 is a combination of newly enrolled as a result of the ACA. They're traditionally individual market population and the MHIP group.
Some of them.
Yeah. And we couldn't, one of the reasons that in 2014, recall, for those that were here, that we made this shift to expand our data collection. And we are not confident with the data we have that we can accurately break out exchange and off-exchange enrollees at this point. We're still actually working with a couple of major payers to get that corrected so that we could, for 2015, what we would compare with 2014 and 2013, have exchange, off-exchange, and grandfathered individual market data to break out, which I think is going to answer and provide some.
Well, and would we? I guess I would expect, and correct me if you're finding different patterns in the data, that the new people coming in through the exchange are going to have a lower risk profile than what you saw before, because now they're subsidized and they can afford coverage, which may explain things like bumps in prescription drugs and some things, because there's a pent-up demand. You know, these people haven't had coverage before, they now have it. Those kind of spikes may calm down again once you sort of meet those needs a little better, right? Versus, you know, simply high-spending, high-risk people who, it's not clear to me, and correct me if I'm wrong, that they're either more or less expensive and more or less being served pre or post ACA. You know, I mean, that's sort of a tough population to deal with, period. And they're always going to be expensive, and they have real needs, so you don't complain too much about it. You know, you're
part of the family.
Right. You don't throw them out. Right.
I would say, just from a volume perspective, the report says that there was an increase about 45,000 at the end of the year in the individual market. It's been said at most 20,000 of those would have been MHIP people. And so that means you had another 25,000 that came from other places. Now, they could have been in large employer, they could have been in small employer. They weren't necessarily uninsured, right? So it's kind of hard to know where they came from. But we will.
Everything in the context of 2014, it's likely to assume that of those 25 that didn't come from MHIP, most of them were previously uninsured. And so, to Commissioner O'Grady's point, time will tell whether once their problems are managed, whether that spike will come down and level off at a level below what we're currently seeing and below what the high-risk pool population who's kind of stuck in a higher spend category would sustain.
Right. I guess I would hesitate back to your point before. When the New York Times calls and says, what is my major takeaway here? What is my story? I don't know that it's a spending story. I mean, it might be, but I don't know that we know. I'm seeing it right now as more patterns of populations being pooled in different ways, and it causes these spikes. And one of the spikes is going to be the per member per month going up. But that may simply be the average of what the high-risk member per month was, and the very, the 2 or 3 other components here, whether they're exchange or not exchange, or whether they used to be small employer and now they're in. I don't know that I would bet farm on that this is somehow prices and costs within Maryland exploded over this time period.
I think you're right. It's not necessarily the prices per service exploding, although the reason I was asking about drugs is you can make a case that there are some prices exploding there. But one thing, I wouldn't get my hopes up that this is a one-time bump of people coming into the system. If you look at the relative costs of the small group market, which has been a guaranteed issue for a long time, and the individual market, which was underwritten until the ACA, you're seeing the individual market come up to the cost of the small group. I wouldn't bet too much on that they're here. They're going to get, the folks coming in are going to get one-time medical care and be done. I think that medical expenses will likely stabilize. They'll stop increasing at the same rate, but they're not going to drop back down to where they were.
Well, do you think that pattern is going to be also the difference between the benefit being off, you're not as many I mean, aren't some of these people, if they're going in through the exchange, they're getting a silver plan or something like that, rather than a high deductible they might have gotten on the individual?
Well, yeah, just if I could, so, they are getting silver plan, and the subsidy, I think about 75% of those that are coming in the exchange are getting subsidies, so it's, but most of the products would be under the definition of high deductible plans today that most people are opting for what would under conventional insurance products be considered high deductible plans. They're being subsidized either for premium or below 200% both premium and co-insurance. So they're really not high deductible any longer when you factor that in. We've actually delayed putting this report out for a while because we've made some efforts to crosswalk this with what has been reported through the exchange, and given the fact that we couldn't map our eligibility to what was reported in the exchange, what we would expect is about in 2014, I believe about 80,000 came through the exchange, and we're not seeing that even in total in the individual market just yet. So we have work to do. It's the 2014 for both in the delivery, the coverage expansion, but also simply we made some data changes in our reporting as well that are still being improved on. So I think the point that you raised too is really a good one, is that melding the high risk pool population called in Maryland the MHIP population with the historically individual market, which had a less generous benefit package typically, and then coupled on top of that the impact of the essential health benefits that were a key element of the ACA. This is sort of what we would expect to see. Whether we'll see this going forward, I'm thinking we're going to continue to see cost growth. The premium directions we're seeing with significant premium growth in the individual market seems to suggest that utilization is growing. I think a lot of payers are quite worried about the cost of operating in the exchange market going forward, and we'll have to watch that carefully. Our role, of course, is quite a bit reduced from where we were regulating the small group market a few years ago, but that doesn't mean we can't offer input. The other last point I would make is that the drug spending in the MHIP population was startlingly high, close to, I believe, close to 30% of total per capita spending for that population, which for a traditionally privately insured population, I think you'd be looking at about a 12 or 13% spend. So, some of the drug surge is just for the very reason that Commissioner O'Grady laid out, that you're getting this population coming in for the first time with a high drug pattern. This is a population that was largely chronically ill.
So I had no idea that the headline would generate such a rich conversation. The point is context matters. So I hope it's within the purview of the Commission, as we release reports, that we also create the forums for this kind of discussion. It puts it in context. And I think that's an important part of how we ensure that our data is interpreted properly. And I thought the discussion we just had was quite informative. And so maybe at our retreat or other ways, we'll figure out ways that we create the space for this to happen.
Go ahead, Ben.
So I think that sort of the strategies that we see with under pretty tight spending limits here, that historically we've had a bit more resources to conduct these studies ourselves. Our strategy going forward, in part, is to try to engage other external groups, make it easier for them to get the data, and do some of the work that we ideally would like to do ourselves. And I think the commissioners, through some of this discussion, hopefully there are some on the outside. This is being broadcast live through the internet, and I'm sure there's a ton of viewers sitting here waiting, consuming this.
Really?
But I think we really have to honestly think about how we promote studies that we think would be inform policymakers here, but we may not have the resources to do it all ourselves.
But I'd like to support this notion because I think this is certainly high-quality actuarial standard. But at the same time, either through the press release that you would put out with it, through an executive summary you put forward on it, I think you have to talk the non-technical reader through some of these factors that are going on here. Otherwise, and God knows I love the media as much as the next guy, but it's going to pull a little tidbit that's going to make a wow, and they're going to run with it when this is a complex pattern of different kinds of data with different kinds of people with different needs and different ways of providing them insurance. So I would be uncomfortable just sending it out. I think you need at least a good press release, if not a front cover that sort of just says a number of things happened in the state of Maryland over the time period covered, you know, and talk a little bit and talk the reader through so they don't run with it in a unconstructive manner.
Well, to that, is such a narrative contemplated with the release? All I see is what's, here. And this doesn't really cover Commissioner O'Grady's comments, and I think for the sense of the group about how important context for 2014 really is. So how would the Commission offer some degree of interpretation to augment the headline?
Yeah. And it shouldn't paralyze us. I mean, it's not uncommon. A lot of things are out there like that. But just what happened here was extremely informative. And I think that the more opportunities we create for that to happen, whether it's here or in some other forum, it really helps the consumer, taxpayer, our constituent, so to speak, interpret it properly.
Mm-hmm. So what I would say is I would love Commissioner O'Grady to send me a few sentences that I would be more than happy to insert as a sort of an orientation to the report at the beginning of it.
I think that what we will do is take the report back and put a sort of this will turn out is a relatively short document. I think a lead-in introduction is what we need to do and run it back by you. Formally, I don't think we need commissioner votes to do this, but I think getting some consensus on it's ready to be released would be, I think, something everyone would feel more comfortable with from the sense of the conversation.
That's my sense of this discussion. So with that, perhaps we could table this motion until next month, bring back a narrative, and then take it up at that time. Is there an urgency to get this?
Well, what I was going to suggest is that I think technically we don't need formal action to get this out, but I think the consensus that it's ready to be released would be something minimally we would want to have. So I think if we can make a stab at that and circulate to the Commission over the interim and get some sense that this is ready to go, that would be fine. I don't think we need an actual vote to get this going, but I'd like to have agreement that it meets some of the recommendations we've heard here, so that there's more of a story.
So we'll withdraw the motion.
Yes, we'll withdraw.
Okay, and we'll take it up soon.
Yes.
Right.
Prior to release, we'll run it back by the Commission.
Right. Good discussion. Is that agreeable to everyone? All right. Good. Thank you.
Okay.
Thank you, Ken. We love your data. Thank you.
I had a question. Madam Chairwoman, I just had a question about the presentation had some additional slides and graphs. Will that be available somewhere? The slide presentation had some additional slides and graphs that weren't in the report. It looked interesting. I was just wondering if a copy of that will be available.
It's always on our Commission website, and we'd be more than happy to send it out to you as well.
And I would agree, and I think in the future, if we could get those before the meeting, just so we have a chance to give you better input in terms of, that would be great.
Okay.
Because I know many of us were looking at our report and going, well, that's not quite chart 4, and so.
Okay, good, thank you. We tried. All right, moving on. We're going to take up some old business, but maybe for the last time. I want to invite Angela Evatt to come up. Angela is the Chief of Health Information Exchange, presenting to us the final regulations for COMAR 102518. This is the HIE Privacy and Security of Protected Health Information final regulations. We have gone, this is probably the third bite of the apple that these regs have been presented in
so yes,
and hopefully this isn't the last presentation I give you, but
no, I don't mean it. Of course.
These were presented in draft as well as proposed, and now this is final. So I will be brief and not redundant to our previous presentation.
Thank you. Go ahead, Angela.
So just a reminder, state law passed in 2011 requires the Commission to develop regulations that protect information that is exchanged by health information exchanges operating in the state of Maryland. These regulations are in addition to HIPAA and ensure that patients' information is appropriately exchanged and protected. The initial set of regulations went into effect on March 17, 2014. The staff convenes an HIE policy board that advises staff around the policies for the privacy and security of information exchange for HIEs. Staff uses those recommendations for the framework in developing the initial set of regulations, as well as in developing the amendments that you'll see today. Over about a year period, staff worked with the policy board to develop the policies for secondary data use, particularly around population care management as well as research, in addition to some provisions around the use of information in emergency situations from participating organizations. Staff considered their recommendations and released draft amendments in October 16th in 2015. During the informal period, we received 6 comment letters, and staff worked with stakeholders as well as the policy board to make changes to those amendments prior to proposing it to you guys at your meeting on February 2016. Just a quick reminder of those provisions. There is an additional section for secondary data use, particularly around population care management. And population care management includes the use of information available through an HIE for population-based activities. This relates to improving patient and population health or reducing healthcare costs. And this is specifically where no treatment relationship exists. Patient's information may be disclosed only after appropriate notice is provided to the patient and the patient is provided authorization. An external and independent review committee of the requesting organization may waive that authorization if certain conditions are met. Additional amendments relate to secondary data use for research. An HIE may disclose data to qualified research organizations for research purposes. Disclosures of de-identified data must be approved by Privacy Board, and disclosures of identifiable data must be approved by IRB or Privacy Board, including any documentation of waiver of authorization. An HIE may charge a reasonable fee, reflecting the direct and indirect cost of preparing and disclosing that data. In addition, an HIE will make summary reports available to the public quarterly about those releases for secondary data use and report to the Commission annually certain information about those releases. Commission staff may require HIEs to conduct an audit of those secondary data use disclosures using a third party if requested. And additionally, if a consumer requests from an HIE should provide an accounting of disclosures made by the HIE for secondary data use. In terms of the emergency access provisions, an HIE must establish and clearly communicate to consumers its emergency access policies. If an HIE allows for emergency access, and then HIE should only disclose information to the healthcare provider if certain conditions are met, particularly the healthcare provider in its professional opinion must attest that emergency exists. The consumer conditions don't allow for that patient to provide authorization or consent. And the information available are known to be available through the HIE is relevant to that emergency treatment. An HIE in those situations must implement technical procedures to document that emergency access as well as audit emergency access. Other proposed enhancements to the current language include broadening the definition of an electronic health record system to include all EHR technology that's not just certified technology, as well as in broadening the specific information within a patient education or notice that participating organizations must provide to consumers, and this is enhanced by the secondary data use provisions. And then also some strengthening of the auditing requirements on HIE. During the formal comment period, staff received comments from CareFirst as well as Kaiser. Generally, and just to note, the detailed letters were in your packet, as well as staff's recommendations for each of their comments. In general, clarification was requested to specify circumstances in which secondary data use applied, specifically in those definitions. And in addition, Kaiser had proposed changes to existing language, and staff plans to review those and consider that in future revisions to the regulation. Staff does recommend two non-substantive changes. CareFirst recommended adding language to the definition of an appropriate notice, and you'll see that in section .02b2, just to clarify that this notice applies to secondary use, and staff agrees with that recommendation to make that clarifying non-substantive change, as well as the change under the definition of research under section .02b52 to clarify that research relates to secondary data use. So we agree with that recommendation. You'll see that within your memo. So staff recommends that the Commission adopt the proposed amendments as final with two non-substantive changes.
All right. Thank you, Angela. The non-substantive nature of these changes means that should the Commission vote to approve, it's final. It doesn't need to go through yet another round of, because they're non-substantive changes. We can just act on them.
Yes.
Thank you. Is there a motion to approve these as final regulations for secondary use? Thank you. Commissioner Thompson. Second? Second. Discussion? Questions of Angela? Comments?
Just to be consistently pain. No, I have a question for you on page 4 of your presentation where you talk about population care management. It just I'm just not totally clear. So we talk about the idea. So we've got somebody, and so I'm just going to use some examples I'm familiar with to kind of as hypotheticals. So we can see through the HIE data, we can see that somebody's type 1 diabetic, and so the insurer or whoever else has got a disease management company that they have, and so this would allow that information to be released to that disease management company to reach out to that person and see whether they wanted some help with going on. Unless, but it says in the third bullet sort of says, but that patient has to say, I'm okay with these people contacting me, et cetera. I think. Yes. So far, am I on the right track?
Correct. Yes, they must provide authorization.
Authorization. But then on the last bullet on the page says, an external and independent review committee of the requesting entity may approve an authorization waiver request if certain conditions are met. Mm-hmm. That sounds like, you know, I'm United, I've contracted with these disease management guys. It sounds a little like I can override what the patient wants this, you know,
so that review
disease management nurse calling me every Tuesday or not.
So the review committee is external and independent to the requesting entity.
Right.
And that review committee would review whether or not the appropriate notice was provided. If for any reason there was no authorization provided within 30 days, and the information, and I forget the provisions are in the regulation in terms of those circumstances. But the information or the analysis in which the data is being requested couldn't happen without the data, and there's limited risk to the patient. So those provisions were put in place in cases where you reach out to patients, there was no response, and it makes sense for that information to be released at a low risk, and the external and independent review committee can provide that authorization.
I see. So if I'm in my hypothetical, so United Healthcare and I have my own kind of IRB quasi sort of independent, outside the mothership kind of organization that does this, and they say, call him anyway, even if he said he doesn't want to be called, or it's only if there's no response?
Right, there's no response.
Okay, so there's no vetoing of a patient's...
No.
Okay.
No.
Good. Just clarification.
Excellent question. Thank you. Other questions? That goes right to, I think that goes right to the heart of our vigilance with regard to secondary use and the security of PHX. So thank you for raising that and walking us through that scenario. If no other questions, let's have a vote. If those are in favor of adopting these as final regulations, please indicate by saying aye. Aye. Is anyone opposed? Thank you. Thank you, Angela. It's been a labor of love, right? It's 2 years now and counting. So going forward now to Tressa with quality, it looks like the Maryland Healthcare Quality Report. You've got an update for us. Tressa Lee is the Director of the Center for Quality Measurement and Reporting, and Eileen Witherspoon, Chief of Hospital Quality Initiative, will present background information and the new Maryland Healthcare Quality Reports website, as well as detailing staff plans to promote consumer awareness and engagement.
Thank you. And good afternoon, Commissioners. What Eileen and I would like to do today is to give you a sort of a brief summary of the staff activities related to our consumer website, the Maryland Healthcare Quality Reports website. And again, for background, what we've attempted to do here is to bring together our consumer guide into one location so we can establish a comprehensive integrated online resource that enables consumers to access accurate and meaningful information provided on healthcare providers and payers. The presentation outline, I will first just briefly go through a background of how we came to creating this comprehensive website, and then focus specifically on our most recent update, which occurred last month, and that the main changes to the website were the inclusion of new HAI data, enhanced information for the hospital industry, and more updated average charge and medical conditions information. We'll also talk a little bit about what we're doing to promote the website. This slide just gives a background on the hospital performance evaluation system and infrastructure that was used to build this more comprehensive website. And our mandate to report to the public on these various providers for hospitals extends back to 2002, and I think for health plans it may be 1999, long-term care facilities. But we have been in the business of providing quality and performance information to consumers for some time. We repurposed the old hospital guide. To the left is the actual website, and to the right is a screenshot of the Quality Measures Data Center, which was actually a website designed to receive data from hospitals, the HCAHPS data and other core measures data historically. We repurposed those websites to create the Maryland Healthcare Quality Reports website, which is a platform that brings together all of those guides that I mentioned before. And we believe that this website lays the foundation for a more integrated public reporting tool, and we also hope that it evolves, because we see this as the foundation and the beginning of an ongoing process of improving the site over time. Again, the site was established with the collaboration with the Health Services Cost Review Commission, CMS, in terms of establishing a data sharing arrangement for the HCAHPS and the core measures data. We use a Monarch tool developed by ARC to help us display the information, the hospital information, and we also engage the consumer through consumer focus groups, and then consumer advocacy groups were a part of the process. So our update to the website, which I mentioned earlier, our last update was in April, last month, and before I turn it over to Eileen Witherspoon to talk about our HAI data, I just want to draw your attention to this document that you have in front of you. and it is the Maryland page from a CDC report released in March, I believe, showing the condition and the status of Maryland performance on these HAI. So Eileen will be referencing that report as she goes through.
Okay, thanks. As a reminder, we currently stagger annual reporting of HAI categories with central line-associated bloodstream infections, Clostridium difficile infection, and MRSA bacteremia or bloodstream infections in April, and surgical site infections, catheter-associated urinary tract infections, and healthcare worker flu vaccinations in July. So this data is reported by the hospitals to CDC's National Healthcare Safety Network. So I wanted to mention that the update to our website is with calendar year 2015 data. I will also be discussing, as Teresa mentioned, the CDC HAI progress report that was released in March for all the states, and this is based on older data to calendar year 2014. So I will start with the good news. The state and hospitals continue to perform better than expected on CLABSIs. There were 175 infections in total for the adult and pediatric ICUs for 2015. And this is a 46% reduction in the number of infections in adult and pediatric ICUs since reporting began in 2010. There is a handout provided in your packet with more detailed information. So statewide performance is better than the national experience or national baseline. I will go into detail later, but this baseline will be changing, and that will impact performance at the state and facility level. I also wanted to mention that reporting was expanded in 2015 to adult and pediatric medical, surgical, and medical surgical wards, and performance is still better than expected in those locations. So we have modified the display on the hospital guide from input from our HAI advisory committee to show the wards as non-ICUs. We did see an increase in the number of infections. However, in 2015 compared to 2014, CDC is also seeing this trend at the national level. And while more analysis is needed, this is likely being impacted by a change in NHSN definitions and decreasing central line days. So the decrease in central line days is a good thing, as central lines are a risk for this infection. Moving on to Clostridium difficile, this is a proxy measure that's based on positive lab results. The state continues to have more infections than expected compared to the national baseline. The state showed 2,355 infections, or 10% more infections than the national baseline in 2015. However, this is an improvement over 2014 when we were showing 18% more infections. So while Maryland's performance is worse than the national experience, we are moving in the right direction. Moving on to MRSA bacteremia or bloodstream infections, this is also a proxy measure based on positive lab results. The state continues to have more infections than expected in this category as well, with 221 infections reported. So the state's performance is worse than expected. Although we had less infections in 2015 compared to 2014, the denominator of patient days is also decreasing, so we are showing no measurable improvement. Moving on to the next slide. These graphs depict the data by year, showing both the number of infections in green and the denominators in blue for each HAI category. As mentioned, CLABSI numbers have decreased greatly since reporting began in 2010, and both CDI and MRSA are showing decreases in the number of infections, but reporting just began in 2014 for those two categories. The next slide shows the Maryland display of the CDC HAI progress report. So each state has a page like this in the full report. The report was released in March, but as I mentioned, the data is from 2014. As you can see, the HAI categories we reviewed are showing similar trends to what we are reporting, and we will be providing 2015 data for CAUTI and SSI in the June-July timeframe. I wanted to mention that the national baseline for these HAIs will be changing to calendar year 2015. So some of the current baselines are as old as 2006 to 2008. So this update to the baseline will erase any progress or non-progress that has been made, and we will lose the ability to trend performance. But we'll know more about the impact once the data is released. I believe it's the end of this year. And then I wanted to highlight some ongoing staff activities that are aimed at decreasing HAIs in the state. We hold quarterly HAI advisory committee meetings to facilitate communication and information sharing among experts and stakeholders. We have changed our monthly HAI advisory committee meetings to quarterly and are supporting the DHMH-led antimicrobial stewardship work group through the use of our meeting room on the off months of the HAI advisory committee meetings. And MHDC staff participates and monitors progress of this work group.
We are also finishing up a targeted on-site audit of HAI data. We'll be holding a webinar in June to review the results. We continue to provide ongoing support and education to the hospitals. For example, we notify hospitals if there's a change in definition and also facilitate communication between NHSN and the hospitals if any issues arise. We partnered with VHQC, which is the state QIN-QIO, to participate in their Maryland hospital on-site data reviews. VHQC was reviewing CLABSI cases for a handful of facilities in the area that had higher than expected number of cases. We are also researching tools and resources developed by CDC, such as targeted assessment for prevention or TAC reports, and we are looking into providing these to the hospitals to help them target units with higher than expected infections. We have also been in contact with hospitals that have access to software that streamlines NHSN data extraction and analysis in an effort to streamline our processes as well. Finally, we support hospital participation in statewide collaboratives and disseminate information to the hospitals when we are aware of programs going on that would benefit the hospitals. So that's the end of my slides, if there's any questions.
Thank you. Questions? Commissioner Pollack.
Yeah, when I read this document carefully, I noticed that we're performing worse than the national average in every category except CLABSI. When you look at CLABSI carefully, when you look at the national SIR of 0.5, we're worse at 0.53 in 2014.
Mm-hmm.
So while we're trending better than prior benchmarks, we're not trending better than the way other states are trending.
You're correct. Mm-hmm.
So we're not doing better than other states in any category here.
Well, I mean, ranking-wise, I believe we're at number 32. So we are under you're correct, based on the national SIR of 2014. So no, that you are correct.
But in perspective there,
yeah,
how well we're performing.
No, you are correct.
Because it looks, when you look at this green arrow and you see down 47%, you say, wow, we must be doing really well in that area. And when you look at what's happened to CLABSIs between 2010 and 2015, that big drop, that's expected nationally, because there's actually been a change in the way we take care of patients with regard to central line associated bloodstream infections. So that does make sense. But some of the other changes that we've started to see, and this is 2014 data, which really becomes difficult to make heads or tails of because so much has changed since 2014.
Mm-hmm.
What's really important to keep in context of all this is the way that the incentives around the system that have changed since 2013 to 2015. So we've gone from an area where your coders are trained to upcode as far as possible, legitimately, but as far as possible within the context of legitimate in 2013 and prior, because your case mix index went up and you got paid more in those situations then. And then after 2014, your coders are trained to do the opposite. And that is to scrub the data when you have it. If it shows an infection, to make sure that it actually shows an infection. And you train people differently with regard to the definitions of infections, so your infection rates go way down. And we noticed, Caudian rates, it's catheter-associated urinary tract infection rates at some centers plummeted after the onset of GBR without any change in the way we actually took care of patients, but with a substantial change in the way that we interpreted and looked at data from center to center, all within the context of the national definitions of how you have to define these things. So I think that, first, when you compare this state to the rest of the country, when the rest of the country didn't go to GBR in 2014, we did. You have to keep that in mind. Keep in mind the difference in reporting that came with that. And second, keep in mind that we're still, despite everything else that we've done to try and ultra-regulate the state, not doing as well as the rest of the country is in terms of preventing infection.
Thank you.
You used the number, the metric 32. We're ranked 32nd in the country out of all the states.
For CLABSI right now.
All right, let me ask you this. Is there a composite score, following up on what Commissioner Pollack has brought to our attention, is there a composite score of quality performance for hospitals that would, for example, put together a lot of these elements? Is there a composite score?
They're working on one.
Who is working on one?
I'm sorry, CMS is working one to pull in the NHSN measures, the quality metrics, the HCAHPS metrics to come up with this quality score.
Right.
But it was delayed, I think, for a couple of months. I'm not sure exactly when it's coming out, but it was delayed.
But that quality measurement is based on things like outcomes, right? Like
It
medical
includes
outcomes.
these metrics. So it includes those metrics that are in value-based purchasing, CMS, the value-based purchasing program.
Yes, yes. But, I mean, what I'm trying to get at is medical outcomes here. There are other things that go into these quality scores that I frankly have problems with, but that's my problem, not necessarily anybody else's. My question, though, is that do we have, is there, I guess there isn't, there's no national quality score, composite quality score on medical outcomes. Is that right?
Not to my knowledge, not at
Okay,
this time.
all right, that's important to know. All right. All right. This is kind of surprising to me. I thought we were actually doing better. I mean, frankly.
Well, I think if you recall, when we started this, Maryland was pretty much the worst state.
We
So
were the
our
worst state in
yes.
the union?
Yes. So our progress was significant because we
How
were
many
so
people know
bad.
that? No, that's pretty bad.
That's not the story you're getting from that.
There's your headline, Commissioner Thomas.
All right, go ahead.
So there has been significant progress, which, as Eileen mentioned, now they're changing that base. That was compared to 2006, 2008, a baseline of that period. So as they change the baseline to 2015, I believe.
Yeah.
So we'll lose all that progress. So that slope will go as we begin to go forward. But the other thing with respect to the upcoding issue, this database is submitted through NHSN, and the definitions are different from the coding definitions, the clinical definitions, because there's a lot of back and forth between physicians and the infection preventionists, because the infection preventionists must adhere to NHSN definitions.
But the definitions are not, there are no absolutes.
I got you, I know. That's definitely
With the coders transmit that information to CMS. And that, the direction,
Yeah, turn it on.
the direction that those codes go is scrubbed. And you make sure that the data is absolutely correct and it meets the definitions, but there are different ways to adjust how you report these things. And you can decide whether you've got a CAUTI or not based on how you monitor things locally.
because I do think with the MHACs, there's definitely, what you're saying is definitely applies to that.
So
And we hear a lot about the
should
coding.
qualify MHACs.
The Maryland
Hospital-acquired
hospital-acquired conditions, right, where there's, CAUTI is a part of that, and the whole issue of coding the catheter. And if it's not coded, then that particular case won't show up in the MHAC.
Right.
So those kinds of issues we're still working with HSCRC on, because we're looking at this surveillance data set, and we're also looking at the HSCRC clinical data set to see where there are discrepancies, and we're finding those discrepancies. So your concern may be valid within the scope of using the HSCRC data to and the GBR and all of that. But this is a little bit outside of that.
A little bit.
Only just because it is a separate
Not
data
completely.
set.
So if the data set you're using defines a catheter-associated urinary tract infection as the presence of white blood cells in a urinalysis taken from a catheter, and you're taking the samples on a daily basis to find out when they occur, and you realize that a lot of times you're getting white cells or you're getting colonization of bacteria within the specimens that's not necessarily a clinical infection, but looks like colonization and reports up as an infection, you're going to stop measuring it on a day-to-day basis because there's no requirement to do so. Yet, if your case mix index goes up when you measure it on a day-to-day basis and you get paid more, you're going to measure it more often. Neither one of those things represents a change in the way the patient actually got taken care of.
Absolutely.
I feel a little bit nervous talking about urinary tract infections here next to a nephrologist on the orthopedic surgeon. But did I get it wrong? All right.
But one just, I mean, that's why you rebase and say, okay, we're gonna start from 2015. Is if you think there's been that underlying behavior that you really can't compare.
But we're
back.
the only state that had that change. So when you take a look at our changes relative to other states, you gotta be careful in interpreting.
But still, I think Commissioner Moffitt had, this is not a good report card.
Terrible.
This
I think it's worse than it shows.
Right. And so the question is what do we, is there, I mean, certainly we report it. We don't try and, we put it out there. But is there a policy implication here beyond other policy decisions that have been made in the past that need to continue to run their course before there's another
issue here, and I hate to continue to beat on this GBR thing, but we have to be careful about telling people that GBR is delivering quality care, because we don't have evidence that it is right now. That's a bad statement to make.
What is GBR? GBR?
Global budget.
Global budget revenue for the hospitals, the capitation system, the rationing system that we have in place for healthcare in the state of Maryland.
Let me ask you this. You were ranking 32nd. What state ranks number 1 in the nation?
I don't know. I can find
the
out.
Best, yeah.
I guess, no, I don't know.
You don't know?
Mm-mm.
Okay, but we were at,
back in our offices.
Yeah, I can
that's
find
all right,
out.
yeah. Let us,
Is that right?
in an email, tell the commissioner, all of us, what the best state was. What are they doing? The point is that, frankly, I've been on the commission for a while. This is the first time I actually ever heard that metric.
Well,
the first time that we actually ranked at the bottom of the country. Maryland, one of the wealthiest states in the Union, ranked at the bottom. This is a big revelation.
I did want to note, too, in our HAI advisory group, they had mentioned that Maryland is an outlier for MRSA, just prevalence in general. So, not that that's an excuse, but they were saying that.
Right.
No,
I think we all share Commissioner Moffitt's reaction, at least to the CDC report, and presumably that's part of what you're proposing to be uploaded to our quality website. It's already out there, so it's not a revelation.
Thank you for reminding me.
I'd like, if you would, Tressa or Eileen, to go back to slide 7, collaboration and consumer engagement, because it seems like this data is, what we're reflecting is it's a call to action. And I think this is the action slide, and I'm not understanding the action too.
Well,
here.
What I was going to mention, too, when we first started collecting this data for CLABSI, for example, and we found that Maryland was number 1, we started to reach out to the hospitals that had the worst performance and talk about corrective action plans. The Maryland Hospital Association, in collaboration with, it was Delmarva, the QIO at the time, there are a number of individuals that started the CUSP program, the Comprehensive Unit-Based program, where there's a checklist to really get the hospitals to follow a checklist to make sure the catheter is in when it's needed. There were a number of actions taken, and it really brought down that. But it was when we first started and we were focused on CLABSI. We've now agreed to collect everything that is required by CMS for value-based purchasing so that we can support the waiver. So it sort of dilutes our focus. So we have all these different data sets. We're just beginning to see that we now have problems in these other areas. And we're not staffed to go out and, intervene, but we definitely try to facilitate, to make a difference through public reporting, and then supplement it also with what's done with the quality-based reimbursement program, which is a feature of the HSCRC rate setting system. So it's not to excuse the performance at all. And that's why we had a slide on what are we doing about it. To the extent we can, we try to work with all these other
is that what this slide
stakeholders.
Is that this slide?
Well, no, there's another one that came right after here, right after the HAI presentation on the status of Maryland hospitals, actually.
Yes.
Just a couple of points. Just to point out the real other problem with this CLABSI point is that the checklist for preventing central line associated bloodless infections, that whole process that the rest of the country used that brought their rates down ahead of ours was developed in Maryland at Hopkins. So
that's right.
We still couldn't figure out how to get it implemented in Maryland hospitals, even though the process was developed in Maryland. You mentioned a CMS quality reporting, aggregate quality reporting system that I believe rated hospitals by stars on an aggregate quality system. And there were some drafts of that were released, and I think you've seen the drafts. I have heard tell of the drafts, and they listed several of the Maryland hospitals at exceedingly low levels.
I haven't seen all the drafts, but I know Maryland hospitals did not perform well.
I think, I don't want to, because I can't quote it exactly, and it's a draft, and they're going to go back and consider what they're actually going to release. But it wasn't flattering in any way, shape, or form. It didn't make this look better. It made this look worse than what we're seeing now.
Yep. And let me also add something that, thank you, Sue Ellen, for pointing out. But Maryland was one of a few states that actually audited the CLABSI data, because this is a requirement for hospitals across the country, but there was no audit of the accuracy of the information. So in Maryland, we actually audit this information, and we found discrepancies and require hospitals to submit that information. So I think we have a better sense here of its quality. And the few states that were auditing at the time were all worse than the other states.
So just to point out the difference between what was happening in Maryland over those years and what was happening in the other states over those years. Things like innovative programs that allowed hospitals to share risk for complications were allowed in other states that didn't have a waiver, and they weren't allowed here. And what that resulted in was major hospital systems being at risk directly for central line associated bloodstream infections, directly on that individual patient. So if you got an infection, you paid for the consequences of it. And if you prevented the infection, you saved the dollars associated with it. In this system, it's a lot different than that. If your aggregate rate of infection goes up, the HSCRC may decrease your GBR, your cap, but there's not a one-to-one relationship. It's much more removed. So in other states, there was incentive for the hospitals directly for a long time to focus on individual patients and be able to monitor individual patients with regard to their profitability. And here, that's never existed. At least hasn't existed since 1978. So it really is a testament to what a free market and competition can do to encourage hospitals to develop safety standards that doesn't necessarily exist in an ultra-regulated environment. And you can take that ultra-regulated environment and do what we're trying to do now, which is try and encourage hospitals to decrease their infection rates. And it's going to work to some extent, but it never works as well as the free market does to do it. And we're starting from way, way, way behind to do it. And I think it's important that that be part of the narrative when we talk about whether or not GBR is working. And when you read what's been published from Nextdoor, you don't see any of that. All you see is the wonderful dialogue about how we've improved with regard to quality. And yeah, we've improved a little bit with regard to quality, but we're not where we should be.
Commissioner Pollack, I like wonderful. So it's a longer conversation that we need to have, and maybe even a longer timeline. But again, look at the robust conversation that we're getting from the data generated. And again, more forums where we can drill down and really understand what's going on.
Thank you, Mr. Thomas. And again, there are parallels to the previous discussion about the private health spend data and the need for some context and interpretation. What you're presenting here and that we're all reacting to is not our data. It's really CDC's data that we would be for which we would be messengers. So I guess I feel less compelled to develop a narrative or a headline for that. It is what it is. It's not well understood, I don't believe, by the public, by consumers. And so this is not an action item on the agenda. This is a presentation, and we are happy to get that presentation. I guess some of the feedback that you're getting registers surprise about this data. Perhaps some caveats if now the upcoding is now downcoding, maybe for 2014 and 2016 we'll see a miraculous improvement. I mean, time will tell on that. But it did strike me as notable that the groups that were not mentioned on the slide that you all are collaborating with. I know you're working with the Hospital Association. I think you mentioned that. But the Office of Healthcare Quality, in terms of the regulatory responsibility for hospital quality, rests with OHCQ in the Department of Health and Mental Hygiene. And so while we're not the regulatory body with regard certainly to licensing hospitals and their performance, I would hope that you are working with them as well. OHCQ.
We do work with them. They're a member of our HAI Advisory Committee. They're a member of our HPEG, the Health Performance Evaluation, Hospital Performance Evaluation Advisory Committee. So we definitely work with them.
Is there anything, thank you, is there anything else that you would like from us in making this presentation, or any other information you'd like to?
I think that some of the points that we've talked about, additional clarification is that the NCDR data is now being used by HSCRC. Historically,
the NHSN.
NHSN. I'm jumping to cardiac here. Is now being used in their MHACs calculations, which I think is an important.
Well, not in MHACs, but they're actually using the NHSN data on the QBR. So they recognize, you're right, the importance of this surveillance data. And again, Maryland, I should say, we were one of a few states requiring this before even CMS required state hospitals to use this tool because they thought it was a better clinical representation.
Channeling Commissioner Stahlenwerk a little bit, recognize. So I think she would say, the patients care about safety, and that the fact is that these results seem to collide pretty directly with concerns that patients, they may not understand cost, and quality is a hard metric to understand, but they do want to be safe. And I think some of our outreach efforts need to really refocus on some of those issues directly with consumers. We have very little in the way of a budget for awareness, but we do have some. I think as next month, Teresa is going to be able to come forward with this recommendation on.
It's the last page.
Okay, this is on the last page. Okay,
Yeah.
I was wondering where it was.
I know. I stopped.
So we're going to talk about that, but I think that unless consumers are more engaged in these issues in a way they can understand, you can't move the needle as fast as you might.
Right.
And whether it's the marketplace or a regulated market, unengaged consumers certainly don't help progress move very fast.
Do you have another slide you want to
Yeah.
get?
I apologize. I stopped for questions with
Can I
HAI.
ask one short question before we do that? I noticed the number of reporting hospitals on the CDC's chart was in the upper 40s out of 62 hospitals. Is there a category of entities not reporting, or is that just for that line they didn't have anything to report? What's going on there?
Our data includes the general acute care hospitals in Maryland. The CDC data includes some other, I think maybe the federal or the VA hospital. They may include a couple of others, but they can't share with us those hospitals so we can tease them out. So it's a little bit slightly different in terms of the hospitals that are included in the two different data sets.
So there's not some category we should be concerned is got infections that's not reporting them or something like that?
No. Through our audit process, we're able to determine whether or not they're reporting them. So I'll skip slide 7 and go to the last slide, which basically talks about how we're trying to promote the website. So this website is now about 18 months old, and we get about 700 users per month, 900 I think in the last month. And we recognize the need to promote it to consumers. And we've actually, these bullets here just review a process that we've undertaken over the past couple of months to get expertise in marketing and public relations to help us get the word out that this website exists and to help us with messaging to the public. We've actually, the quality team has reviewed about 14 proposal submissions, and we've identified a vendor. We just today got the references checked, so we'll be moving forward with a vendor. We just need to let them know before we publicly announce it. But they will help us with Facebook posts, assisting with messaging and creating digital ads and other, like a video with audio on our website. So there are a number of things that we're trying to put together. And I just want to remind you that on the landing page, the home page of our website, we purposely created these feature areas where we hope to have stories that we can change periodically. Infections is one that we have. Cost is one. But it was something that we put as a placeholder almost to start this out. And as soon as we're able to get fully staffed, we hope to create stories such as this. We may talk about CLABSI, creating it in a way that is easy for people to understand. Right now we have information there about what the consumer can do to help prevent or to help talk with the doctors. There are just a number of pieces of information that are there now that we'll work on and try to collaborate with the academic centers to see if we can get interns or others to help us write some of these. So we do recognize the need to improve and do further outreach, and we're working toward that as well. So that concludes our presentation.
Great. Well, thank you very much, Tressa. I encourage all of you, if you haven't had a chance, to go on the website and check it out. There's always something new there. Maybe not always as eye-popping as what we saw this afternoon, but thank you. We're not killing the messenger. We appreciate that. Thank you. All right. Ben and I are now digging into the M&M, so it's that part of the agenda. We're calling up agenda item 8. This is a new presentation for the first time. It's a presentation on a draft state health plan chapter update for organ transplant. By way of background, over the last 6 months, the MHCC has held meetings of stakeholders to discuss modifications to the state health plan chapter for organ transplant. Eileen Fleck, Chief of Acute Care Policy and Planning, will present the draft changes to this health plan chapter, which will be released for informal public comment on May 5th.
Thank you. Good afternoon, everyone. So the organ transplant chapter was last updated in 2002, and the decision to revise it was prompted by the Johns Hopkins Healthcare System petitioning for an update. And as our chair mentioned, the work group met actually 4 times between October 2014 and July 2015. In my presentation today, I'll talk about some background information regarding the regulation of organ transplant services. I'll then explain the basis for the policies included in the draft chapter and explain the current approach for evaluating the need for additional programs, as well as a new proposed approach for it, which will include docketing rules, which I'll explain. I'll also discuss the project review standards and then the next steps. The National Organ Transplant Act of 1984 provides for the establishment of the National Organ Procurement and Transplantation Networks. The primary goals of this organization are to increase organ sharing effectiveness, efficiency, and equity. And the organization that serves in this role is the United Network for Organ Sharing, also known as UNOS. UNOS develops, monitors, and enforces the rules governing allocation, procurement, and transplantation of all organs except for the bone marrow transplants. UNOS divides the U.S. into 11 regions, and within regions, organ procurement organizations, OPOs, are designated by the Centers for Medicare and Medicaid Services. And there are 2 OPOs that serve Maryland jurisdictions. As you can see on this slide, there's one OPO, the Living Legacy Foundation, that serves all of Maryland except for 3 counties, Montgomery, Prince George's, and Charles counties. And the second OPO, the Washington Regional Transplant Community, serves the 3 Maryland counties that I just mentioned, several counties in Northern Virginia, and then also Washington, D.C. So residents from Maryland or from outside of Maryland can choose to get on wait lists in either OPO. It's not restrictive in terms of the boundaries of the OPOs and where people can get transplants. In the current state health plan, the boundaries for those OPOs define the health planning regions for organ transplant services, and the draft state health plan chapter maintains the same definitions for health planning regions. Given the role of the OPOs in encouraging organ donation and coordinating that process, we think that it makes sense to continue using those boundaries for health planning purposes. And although not shown on the map, I do want to mention that there are 2 hospitals in Maryland, both academic medical centers that provide transplant services, the Johns Hopkins University and the University of Maryland Medical Center. There are a few hospitals in D.C. that also provide transplant services, and Inova Hospital in Fairfax County also provides organ transplant services. In the current state health plan chapter, there are 16 policies, many more than the 6 that are included in this draft chapter. This change reflects moving some of that content from a policy section to project review standards. The policies in the draft state health plan chapter are consistent with those in other chapters that have been recently updated and emphasize cost effectiveness, quality of care, and access to care. In particular, access to organ transplant services has recently been a major focus of UNOS, leading to changes in the allocation policies for liver transplants and kidneys. Changes in the heart allocation policies also are under review. A few policies in the current state health plan chapter are not included in this draft chapter based on recommendations from our work group. For example, there's not an explicit policy stating that fewer organ transplant programs operating at higher volumes is preferred. Also, the policy requiring that a new program be at a teaching hospital or affiliated with a teaching hospital was eliminated based on the work group's recommendations. And then also the policy regarding the reporting of certain information and the evaluation of programs every 3 years by an independent group of transplant experts was also eliminated because it was regarded as unnecessary given the available public data that's reported and then also the oversight by CMS. The current state health plan chapter includes a need projection methodology, but we have proposed not including one in the draft state health plan chapter. We are concerned about the volatility of the projections from year to year in the current methodology, which is partly due to the low volume for some transplant types. And so the result is that it may look like there's a need for a program in one year, but then the next year, suddenly there's not a need for a program, so there is quite a bit of fluctuation from year to year. We did consider making some changes to the methodology, but those changes didn't seem to yield better results. The work group members agreed with the staff's concerns, and they were also concerned about recent changes to the organ transplant policies for liver and kidneys, and that those changes wouldn't really be sufficiently captured given the lag in the data available. So the current need projection methodology, it has a projection for each of the 2 regions, and it relies on historic case volume information at the transplant centers for a 3-year period, and then it uses the projected population growth to make assumptions going forward about the trend in future years. It includes all age groups in the pediatric hospitals. It does include both the deceased organs and those from living donors. And it does also account for the migration trends. And similar to other projections that we have, it assumes that the historic migration trend will also be consistent in the future. And so ultimately, the need for an additional transplant program exists if net need for transplants in the region is greater than the threshold volume standard for that type of organ. And the threshold volume standards in the current state health plan chapter are used as a guide for measuring adverse impact on existing programs. And in combination with the need projection, they serve as a barrier to even considering a CON application for a new program. So currently in our projections, there is a net projected need for a liver transplant program potentially in both of the health planning regions. But other than that, there is not a need projected for any of the other types of organ transplants. And so on this slide, I've shown the threshold volume standards, which, as I just mentioned, they come into play in terms of are we going to consider a new program. And so the highest one is actually only 50 for kidney transplants for adults. And most of them are around 20, like for liver and heart and lung. And under the draft chapter, we're going to maintain the volume threshold. So I have included here the current threshold volume requirements and then the proposed requirements. There aren't a lot of changes here. It's pretty consistent, but in some cases, the work group had recommended that we not have a requirement or that we make a change. And so in this draft, and on this slide, I just wanted to show you what the actual volumes are, because in some cases, the threshold volume standards are pretty close to about the volume that seems to be going on. Like for heart transplants, 20 is the threshold volume standard, and then you look at the number of cases, and it's 17 at one program and 24 at another program. But for kidneys, where the threshold was 50 cases, right? Like if you look at the both programs, and they're both doing over 250 cases, so it's well above the threshold volume standard. And then if you look down near the bottom for pancreas and the combination heart-lung transplants, those are extremely low volume. You may not even have any at a program in a year, and so those are the ones where we have no requirement, which I think makes sense given how small the volume might be in a given year. So in terms of this draft chapter, we are proposing to have some docketing rules. All existing non-federal organ transplant programs must have been operating at the annual threshold case volume standard for at least 3 years prior to filing an application, unless an organ transplant program in the health planning region has been designated as a member not in good standing by the OPTN. And so if that, for a program that's not in good standing, the volume there would not be considered a barrier. We think that makes sense. We've taken a similar approach in terms of cardiac surgery, where there's less consideration given if a program seems to be not doing well. A program does have an opportunity to improve, and so it wouldn't be something that is quickly reached in terms of that type of standing. And then the other criterion that we are looking at is that all existing non-federal organ transplant programs in the health planning region that are doing transplantation of the same organ type have been in operation at least 3 years. So the idea is that if we've just approved a transplant program or if a new one is just opened up in a region, then we shouldn't already be considering another one. that quickly. We should give it a few years to get established. And so actually, there is a program recently that was opened in the District of Columbia for kidney transplants at George Washington University Hospital about a year ago. And so given what's in these draft regulations, it would be a couple of years before another program would be considered in the Maryland counties that are in that same health planning region. In terms of the project review standards, an applicant has to demonstrate that a new or relocated organ transplant center is needed. And we've also included some specific guidance to an applicant in terms of what sorts of things should be addressed in their analysis, such as the ability to increase the supply or use of donor organs for patients served in Maryland, projected volume shifts for the program in the 2 OPOs that serve Maryland residents, and utilization trends in the health planning region for the proposed program, and the jurisdictions in which the population to be served resides. Another project review standard is the minimum volume standard. And for this standard, an applicant has to demonstrate that the proposed organ transplant program can generate a minimum annual case volume as defined in the State Health Plan chapter within the first 3 years of operation. And that standard is one that's in our current State Health Plan chapter. It's actually pretty similar. We're not making a big change in that requirement. In terms of the access standard, each type of organ transplant service should be accessible within a 3-hour one-way drive time for at least 95% of Maryland residents. That's also a standard or a policy that we have in our current State Health Plan, so that's not a change in terms of that. What is new is having an opportunity for a program to be justified based on other types of access barriers, which is similar to the approach that we've taken in other recently updated chapters, like the cardiac surgery chapter and acute inpatient rehabilitation services. And in terms of the cost effectiveness standard, there is not a cost effectiveness project review standard in the current State Health Plan chapter, but it is covered by other regulations where an applicant is required to generally address certain criteria. And so this standard just spells out more of the expectations for applicants in terms of the analysis expected, where we expect them to explain why the existing programs can't meet the need for an organ transplant for the proposed population to be served, and to also look at the proposed program and how it will benefit the population to be served, and to quantify those benefits and to the extent feasible, and then also the costs. And then also looking at the cost and benefits to the healthcare system overall. For the impact standard, a proposed program shall not interfere with the ability of existing programs to maintain at least the annual threshold volumes, and it shall not have an unwarranted adverse impact on the financial viability of another hospital's organ transplant program, the quality of services provided, or patient outcomes following organ transplantation. There are just a few other project review standards that I want to mention. There's a standard requiring UNOS certification for solid organ transplant programs, and for the stem cell programs, accreditation by the Foundation for Accreditation of Cellular Therapy. And that's consistent with the current State Health Plan chapter. The standard for health promotion and disease prevention is also consistent with the current State Health Plan chapter. There's not a big change with that. The current chapter does not include a standard for comparative reviews, but we typically have included a standard in other recently updated chapters to address that situation. And the standard states that when all the applicants meet all the policies and standards in the chapter, then the Commission will give preference to the applicant with an established prevention or early intervention program addressing the specific medical conditions leading ultimately to transplantation. In terms of the next steps, we'll review the informal comments that we received. The deadline for those is June 1st. And then we'll likely put together draft regulations that have been revised. And hopefully within a couple months, we may be able to bring proposed regulations for consideration to the Commission. So that concludes my presentation. I'd be happy to answer any questions.
Thank you very much, Eileen. Questions?
I apologize if it was somewhere in the presentation that I missed. When you define a program that's currently doing transplants, is that defined by the current hospital location in which the transplants are happening, or could it be anywhere within the health system if multiple hospitals are within a health system?
It's a specific location.
So it's defined by the location. Okay.
Yes. So like if someone wanted to relocate, we would consider that something that's subject to a certificate of need review.
And if a system wanted to offer organ transplants at another hospital within their system, that would be considered a relocation as well?
Yes, I think that's how we would treat it because it's
To the same program?
you're changing locations, right?
Well, it wouldn't be a complete change of location. For instance, they wanted to expand services to multiple facilities within their same system.
I think we'd consider that a new program.
The new CON. Okay, thank you.
Anything you want to tell us?
No. Yeah, I'm just a little concerned that there's a number of things you brought up here that are pretty anti-competitive. So the idea that no one could get a CON if it might impinge on the financial viability of their competition. The idea that someone gets a CON and they block anyone else from getting a CON for 3 or 4 years so they have a chance to get up and running before they face any competition. Who are we protecting here? The patients?
Well, I mean, first I would say, like, I wouldn't think of it as they don't face any competition because typically they're existing programs, right? Like a kidney transplant program. There are other existing
Protect the old guard. I mean, I understand that there's a policy goal in terms of making sure you have enough and a viable program.
Right.
But the barriers to entry from anyone else seems pretty high, unless I'm missing something.
Well, in terms of like the impact standard, I feel like that is pretty similar. Like we normally look at financial viability when we're evaluating the impact for different services. And I think a lot of times, given that, you have a whole hospital, sometimes that if we have one program at a hospital, then having, some negative impact on another hospital's program isn't necessarily threatening the financial viability. So I don't see that as like a low bar. I think of that as actually being a fairly high bar in a way if we're talking about threatening the financial viability. I mean, the idea is to
run through this in terms of just this. So if the DC organized, kind of centric one wanted to basically think they've got a good system, they've got a good way of doing it, and they want to start offering in Baltimore, are they allowed to?
They would apply for a certificate of need, and we would consider it. But right now, in our projections, there's only a need projected for liver transplant programs. So currently, I would say people are shut out in terms of any other type of transplant service they want to provide. I mean, we actually saw this as opening up the process a bit so that there would be more of an opportunity for someone to make a case, like if they're concerned that there's not good access to services because of how existing programs are operating.
Yeah, I guess I'm just a little, we see sometimes where you want to kind of constrain things because you're a little concerned about, provider generated demand for service. I don't think on kidneys and lungs we're too worried that, somehow your doc is going to talk you into maybe, I'm not, maybe. But if they say, he's got extra kidneys in the back and needs to use, I'm being flippant, but I'm just concerned that this does. I don't know how I would come into this market if I was, moving here from Chicago and I thought I had a better idea of how to do this more efficiently, more cost effective, more clinically effective. How I would ever break into this established structure that seems if you got in early, you're in. If you didn't, you're pretty high bar. I mean, like I said, I'd love for you to tell me I'm wrong, that this is sort of an open system that would allow fresh blood and fresh organizations to come in. It just didn't sound like it from the.
Yeah, I mean, I would say the adverse impacts standard has been one that the commission historically has interpreted very cautiously and really made existing entrants really make the case that they would be adversely impacted before that by itself is a compelling reason for not awarding a program. Not the organ transplants are something we haven't seen a lot of, and I think our thought was we were opening it up somewhat, but I think we would probably say that the history of the commission dating back probably several decades has been adverse impact is looked at very tightly. It's a criteria, but it's not one that is, everyone cries adverse impact. So it's very prudent of the commission to look at it very, very carefully. But it is, you're correct, a criteria. A future commission, could opt to do that differently, and it may be that we want to get some input on that through these regulations.
Right. I mean, I would also say that this is different than other services in that it's seen as like a zero-sum game potentially. Like there are only so many organs out there available, and so there's concern that like if we add a program, well, we're just taking away from the existing programs, and what have we accomplished by having 10 happen here and 10 happen here instead of 20 at one location?
My concern would is you would get a better service. You wouldn't get necessarily more organs. But the idea of protecting a status quo set of providers is troubling. If someone has a better way of providing this, not that they'll necessarily come up with more organs or anything else, same zero-sum game, but it's in economics we call it a guild. You've given out union cards to the people who can work in this shop, and nobody who doesn't have a card can't work there, even if they're better workers.
Right. I mean,
Mr. Thomas.
So let me twist it this way.
Keep twisting my words. No.
I'll put it in a different context. So, for example, if you would break that data out by race, ethnicity, you might find that you have disparities in certain populations who are in need but who are not getting that service. Now somebody's coming in and saying, I can make sure that people who have been left out of the organ transplant system for whatever reason, disparities, racial ethnic disparity groups, I can do better. Should I be locked out? Okay, you're saying you have to come in and you have to make your case. So I like to begin seeing these data broken out that way, because there are populations on dialysis and dying before their time because they can't get a kidney. And maybe there's a better way. And if they're getting locked out, then the status quo. They're always going to be in that disparity group. If I'm hearing you right, you'd say that organization would come with a certificate of need and make that case. Is that correct?
they would, but I guess I would also say that, I mean, there is still that standard about, like, if we just had a new program open, you know, in the last 2 years, we're going to still wait some period of time before considering a new one. So I guess you could say, even in that situation, given what the regulations say, we would still be saying to them, like, well, we just opened a new program, so unfortunately, we're not going to consider your application. So there are these docketing rules. There are these rules that I just mentioned where potentially someone is shut out. So that's
Commissioner Sargent.
So I guess I was going to ask a question that's sort of a similar vein, is in addition to disparities within the state, there may be folks willing to travel out of the state to a different facility. Is there any measurement of what the available need would be rather than measuring what programs in the state are already providing? It would be good to know before you accept an application, is there a big unmet need that's viable, that there are organs for it, and you could get the surgery if there was someone to provide it beyond the existing providers? Or are we stuck with measuring how many were actually provided?
No, I mean, there's a wait list. And the wait list far exceeds the supply. I mean, that's the issue. Like, there are lots of people out there who need a kidney, and in that case, there are living donors potentially, and so someone could find a living donor as opposed to waiting for a deceased organ.
And I might be interested to know on the commission if there's a lot of people going to Delaware because they like that program, but they don't, you know, then maybe there's something wrong with the ones, not that, you know, I don't really think there's anything wrong with our medical stuff. But it would be good to know that before we decide that, well, these programs they're not at the threshold, so therefore no one else should apply.
Right. I mean, it is a small number of residents, I would say, that go out of state. We can get some information from UNOS. Normally what we would ask for when we're doing the projections is information for each OPO and looking at the Maryland residents, and did they stay in their region or did they go to a different region, and was that the region next door or was it a totally different region altogether, and, you know, the type of organ donor that they had, was it living or deceased. So there's some information that we get. We can't get from them information like at the zip code level or the county level. They don't want to give us that detailed information, but they have been okay with giving us stuff
Right.
at these large regional levels.
And I guess my question was sort of combining what Commissioner Thomas had said is I think what he was talking about, what I'm talking about, is sort of the same thing in the sense that they're an analysis of is there a practical need out there that's not being met. Not a theoretical one, but a practical one that there's somebody that would pay for it and there's an organ and it's just not being met. It seems to me that we may want to know that before we just apply a threshold based on counting what actually happens.
Okay, we'll have two more comments.
So in reality, there's absolutely a practical need, but the limit is the number of organs available. It's not a lack of places to do it. And so I don't disagree with what you guys are saying, but this is what I do. And I can tell you that the rate limiting is really the number of organs available by leaps and bounds.
So I have a question about these threshold volume standards and the work group that you worked with to develop these. I assume that included people from the two centers in Maryland that are currently
Yes, the two centers and also the OPOs, and then we did have someone from CMS and someone as a consumer representative. But
so,
they were really, go ahead.
Well, you came up with, there's a couple things. First of all, you have threshold standards, and then you have one center not meeting the threshold standard in one area in Harts. Is there any concern about that? Do we need two centers doing Harts?
Well, we have minimum volume standards, which are different. I mean, I would say right now, we don't take away someone's opportunity to provide organ transplants. So once you get approved, if you meet, you're meeting the minimum standards within the first few years, then you're approved, and we're not considering shutting programs down. So that's not something.
You're good forever at that point.
From our perspective, yes.
Okay.
But CMS does provide oversight.
Got it. And then the other thing was you said the only thing that's open right now is liver.
Yes.
But the two centers that you have are not knocking it out of the park with regard to the threshold relative to the number of livers that they're doing, yet they're all 5 times the number with regard to kidneys, and we're not open to do kidneys in other places.
Because of the need projection. So that's what we're removing. We're removing the need projection that, we see as problematic, where potentially, it shuts people out one year, it allows people the next year, then it shuts them out. And so, that's the reason why I say, we feel like we're opening up, because we don't have this need projection that we have concerns about. It's just if the programs are at threshold volumes, which in the case of kidneys, that threshold is pretty low. It's 50 compared to what's going on right now. I think it's more the issue of if a new program gets established, it would be a barrier, but not the threshold standards for something like kidneys or livers.
Yeah, that does reek of anti-competitive.
Yeah. I want to kind of bring this to not to a close, because we will be reviewing these regs again. They were released for public comment last week, I guess, as informal. And so we've got for sure stakeholders on your work group and others will be weighing in, and they will come back to the commission.
Right. We always post the comments that we receive on our website, and then we do address those comments if we bring you proposed regulations.
Great. Okay. So we'll have another opportunity to go forward with some discussion on it.
Yes, but it is good to hear concerns.
Right. Is there anyone that has something that they want to get off their chest?
Just want to get one thing off my chest. The only thing that bothers me about this is related to what Commissioner O'Grady raised, and that is we're in a period where there has been a doubling of organ donation in the past 20 years, according to the data that you presented. 30 years. The point is that there is a doubling of the number of donors. About 124,000 people in the United States who are waiting for organ donation. My concern about all of this, and I guess we're going to have to work all this out, but and I defer to the members of the medical profession who are here, but this is an area which I'm sure where you're going to see a tremendous growth in advanced medical technology and surgical techniques as time goes on. And the opportunities to actually do this are probably going to get greater and greater. I mean, we're going on the trend lines are going up in this area. It just seems to me that what we don't want to do is we don't want to have a regulatory regime that establishes some kind of a brake on innovation in this area. So I think this is actually a very sensitive area. And I think, again, I defer to my colleagues here in the medical profession. They would know much better than I about the potential problems in this area. But I think we got to make sure that when we do this with due diligence, dealing with everybody we possibly can who has expertise in this area, because it's a very controversial area, it's a very sensitive area, and one thing we do not want to do is we do not want to lock ourselves into a position where 2 or 3 years down the road, we're going to regret the regulatory decision we made. That's all I have to say about it.
Thank you very much.
And I just, one last one, I promise to keep it short. Yeah, you brought up before, and you're right, that one that if you're filing a CON, you get it, you block anybody else for a few years. That is, I mean, there's certainly a strategy that would say, I think I want to do this, I'm going to jump ahead because I think my competitor is going to try and do the same thing. So that one in particular is a sore point in terms of my thinking. Just, boy, we really are keeping it to the established players. We're facilitating their. I mean, we're setting up a situation here that you're going to have kind of stagnation, I'm afraid, that you're not allowing openness. And as you think about this and you get your different comments, yes, please take into account the comments of the commissioners here that a more open, a more vital, a more in tune with where the patient needs are is where many of us would like to go, rather than it's protecting the status quo.
Okay, with the discretion of the chair, I'm going to make one more comment. Okay. to pick up on the limiting factor being the organs themselves and the waiting list and the people at need, and there may be disparities that are reflected in that waiting list. That's dependent on these things called OPOs. That's not the hospital, right? That's the procurement organization.
Well, no, I mean, I would say that they're managing that. I mean, they want to see hospitals getting patients to agree that, they want to donate their organs.
Well, some do a better job than others.
Right, yes. I mean, that's something that they're tracking.
So where I'm thinking is, could we leverage our decision making here to encourage better performance? I'm not saying our OPOs are not stellar, but could they do better in terms of, we're not directly dealing with the OPO, we're dealing with the hospital. But the OPO is so vital to this whole delivery of organ transplants. And is the OPO doing the best practices, the ones that work in Maryland, with regard to outreach, particularly in minority communities? That's our supply chain, so to speak.
Right. I mean, we just see it as we want someone to have the opportunity to make a case about access. If they feel like they can do more in terms of increasing access to organs, or showing that there's new technology that allows them to use more
standard. We would look at that in the review.
Yes, I mean, that is the idea. That's something that we talked about, looking at.
Okay.
Yes.
That's a factor. Okay. I'm happy. Thank you.
Okay. Thanks.
Everybody's happy? We're happy. Okay. Thank you, Eileen. We're going to see you next month. We'll take it up again.
Maybe.
Maybe July then.
I think we will get some comment. I think there's one organization is interested. I'm not sure how many more are, but we'll definitely get some comments, I think, and we'll be sharing those with you. Last item,
upcoming
if I can jump ahead,
initiative.
Is we do have I'm not sure, Srinivas has always done this, but I'm sure we'll have a very capable staff present you a request for MCDB data from the University of Maryland School of Public Health. We've been working with them over the last several months, and I think their application is ripe for consideration. We'll also be looking at refreshing some electronic health record incentive regulations that have been in place for a number of years. We're refreshing those. The private carriers have indicated a willingness to continue to provide those incentive payments to practices here in the state of Maryland, and we'll be bringing those to you. Mentioned last month that we were about ready to bring forward our 4th round of telehealth awards. We expect to award 1 or 2 of those, perhaps somewhat larger than in the past. These awards will focus on engaging primary care practices in effective use of telehealth technology. I also mentioned at the outset that there will be a rural health work group member and share recommendations that we'll want to bring to you for your confirmation, and very likely at least one CON application. But I've learned from the past that it's best not to predict exactly which. We have several that may come before you, and we'll wait and give you sufficient notice. We heard comments, and we'll work to make certain that the final presentations that you see are available a bit quicker. That is the Friday before the commission meeting. I know that we strive to make something available, but something that you oftentimes see gets revised in that 4 or 5 day window between when you get your first announcement and when you actually get to the commission meeting. We'll work to make sure that as much as possible is final on that Friday before the commission meeting, when we send out the alert that the website has been updated. So thank you very much.
All right. Motion to adjourn? Second? Motion carries. We didn't even take a vote. Okay. So, thank you all.